Start? Yeah. So, welcome to today's edition of Sahyadri's Oncology program. We thought we had a great interaction last time, so we'll keep it as interactive as possible. And instead of boring you with a lot of data, we just discuss practical cases from the diagnosis to the most recent management that is available. We focused a little bit more on women cancers because we heard there were a lot of gynec people coming in, but we are happy to discuss oral cancer as well for the ENT and general surgeons if the demand is there. So I thought I will start off with a little talk on the recent advances in the diagnosis and management of women cancers. We have just celebrated International Women's Day, and it's been, I don't know why we have to celebrate Women's Day when every day is really about women taking care of the men. So sorry about that, but that's the truth. So without further ado, let's start with what's happening in oncology. So the practice of cancer treatment has changed very much so substantially in the last 30 years. And in the 1990s, when I first started my training, in fact, I started my training in 1993 at Tata Hospital, we saw a lot of improvements in supportive care because a lot of patients used to vomit all the time, they used to get low blood counts, and we had antidotes finally called growth factors for this. We also had a drug called ondansetron, or NSAID as you know it. It first came when I was a student, and I still remember that Glaxo brought it in, and the cost of ondansetron was almost like 2,000 rupees a vial, and the very next month Cipla came in with a vial costing 40 rupees. So I still remember that whole discussion and how Glaxo had to close down its operations in India. So not only that, when I trained in Australia in 1999, the drug paclitaxel came into clinical use. So it had been found in the forests of North America. So what people do for drug development is they actually go into the forest and they bring back herbs, different looking plants, and then it is analyzed in the laboratories by the National Cancer Institute. And one such plant was from the Taxus baccata, which is the yew tree. It grows in India in the Himalayas and is known as Taxus indica. And they brought back the fruit, the leaves, and the needles of this tree. And on examination, they found both paclitaxel and docetaxel were the active principles. And this was first used in ovarian cancer. And it revolutionized by improving the survival by 1 year. So 1 year in oncology is a lot for a patient who's expected to live for 3 to 4 years. You can imagine, you have to look at it in perspective. And then of course we became smart. We started developing nanotechnology. And one such example is a small molecule called liposomal doxorubicin, where it's coated with lipids and a phospholipid layer, which makes it last in the blood for 51 hours as a half-life compared to 3 hours with the normal doxorubicin. So you can imagine it is more effective and it is less toxic, especially to the heart. So smarter ways of delivering drugs were found. And the knowledge, and I really think that the future belongs to genomics and genetics. Everybody is going to, 5 years from now, have their tumor profiled, and the treatment is going to be tailored to that. And we are already getting there. Sahyadri is starting a precision oncology unit very soon, and we are going to have molecular tumor boards, biobanks, and experts to help us treat these patients well. So that is what the cancer cell looked like in 1975 on your left. And this is what it looked like 30 years later, and it's far more complex now. We know each and every pathway of the normal cell. We know how it has changed in cancer. We know the driver of the cancer, the driver change or the mutation as we call it. We know the passenger change. Then we know we have to attack the driver, not the passenger. So things have come a very long way. And this is something that all our oncologists have been looking at since the year 2000, last 20 years. It's called a heat map. Okay? So very simply, what you're seeing in red are the genes which are activated, which are hyperexpressed, overexpressed. And the green is the genes that are underexpressed. So it's very easy to read, and you can see that going left to right, there are different patterns. So these are 3 different diseases, 3 different subtypes of breast cancer. Okay, so it's quite amazing, and we're able to attack these different changes with different molecules, antibodies, and small molecules, which we call IBs and ABs. So IB is a small molecule, gefitinib, lapatinib. Whenever you hear IB, it is a small tyrosine kinase inhibitor which crosses into the cell and kills the downstream pathway which has been activated. When you talk of AB, like trastuzumab, cetuximab, it is an antibody, AB. Alright, that is a large molecule which is blocking the receptor on the cell, and this is something you will be seeing in prescriptions, so don't be confused in the clinic when you see what the patient is taking. So like I said, we have newer treatments, we also have immunotherapy, and what is the next step? That by checking your circulating DNA in any one of us, we can pick up early cancer at that level. So it's going there. It's not yet refined, it's in trial stages. But we're going to be able to diagnose cancer when it starts at the molecular level. The question then is going to be, how do you find out where it is? So that is where we are struggling with. But this is the kind of technology that is coming in. Now, for example, a patient of breast or colorectal cancer or lung cancer has completed treatment. You want to know, your PET scan is normal, but you still want to know, is there any disease left? So you check the DNA on the blood for tumor DNA. And if you find it, you know that a year later the patient will relapse. How does this help you treat the patient? You make a vaccine. That is the next step. You make a vaccine for that abnormal DNA, and you kind of prevent the relapse from happening. So this is where we are headed with technology. Coming to breast cancer, it is really an epidemic, and frankly speaking, I'm really tired of seeing young women, older women walking in, ignoring their health, coming with huge lumps, axillary nodes, and locally advanced disease. So it's up to all of us to make our patients breast aware. You need to, in your clinics, talk to the women about screening, do a breast exam, and encourage those over 40 to have a mammography. So it makes up over 25% of all women cancers, and this is 2020, where we had 1.8 lakh new cases. And at any such time, there are about 5 lakh cases in India, which are prevalent. And we have over 10 lakh survivors of breast cancer in this country. Yes, women who have survived breast cancer. So this number is growing. And as you can see in India, unfortunately, the mortality is more than half that of patients diagnosed, telling us they're coming late, telling us they have no access to care. Dr. Rahul will be conducting a case on breast cancer. So I'll just say that triple assessment is important in the diagnosis, and one must pay attention and not just do 2 out of these 3 things: physical exam, imaging, and pathology. For understanding breast cancer, it's not one disease. Simply put, it's 3, but honestly speaking, it's about 20 different diseases at the molecular level. And we treat them according to ER, estrogen receptor positivity, HER2 positivity, and triple negativity. So this makes a difference. When they are estrogen receptor positive, hormone therapy is more important. When they are HER2 positive, targeted anti-HER2 is more important. And when they are triple negative, chemotherapy, and more chemotherapy. All right? So in inoperable breast cancer, so you will ask me, why give chemo first if a patient has an operable breast disease? And I'm sure Dr. Rahul will talk about this. Earlier, we only gave chemo to inoperable or to shrink tumors women wanted to conserve their breast. But now, why we give chemo up front to smaller tumors and any lady with a triple negative or HER2 positive, because they respond beautifully to chemo and they get a complete response in the pathology. And if they don't, they are at a high risk for relapse. So you know who they are and you can actually change their treatment post-surgery. And you can save some of them. So this is very important. It's called risk adaptive therapy. So we move then from really big tumors to smaller and smaller tumors where we are doing neoadjuvant, that means before surgery. Alright? And so like I said, patients who do have disease remaining after this treatment do very badly. So you can rescue these patients. Then the question arises, Doc, are there any patients where you can avoid chemotherapy? Certainly. So these are the patients that have very small tumors, node-negative disease, and of course a lady over 75. I'm not going to tox her out with chemotherapy, especially if she's estrogen receptor positive. So we actually have tests in the clinic. Even a young woman, say a 50-year-old woman comes to me. She has a 2-centimeter tumor. Everybody has told her chemo, chemo, chemo after surgery. And she has no nodes. I can actually order a genomic test which will put her in a low, moderate, intermediate or high risk. These are 1/3, 1/3, 1/3. And if she's in a high risk, then only she needs chemo. So there are genomic tests which tell me more than the tumor size, more than the nodal burden. These are still expensive, but we have some that are made in India and it saves the patient unnecessary chemotherapy. I do order them in the clinic. There are a lot of advances in surgery. I'm sure that will be covered as well in the case, and a lot of focus on avoiding the dreaded complication of lymphedema. The treatment of HER2 positive has been so gratifying for medical oncologists. Like I said, you can see those Y-shaped structures, those are the antibodies. And earlier, we gave this to patients with stage 4 disease. So we have a bunch of patients like this. You can see the tumor on the right side. It's in the breast, it's in the axilla, and just above the bladder, you can see this huge nodal mass which is there. So this lady came to us 3 years ago before COVID, and we gave her these 2 anti-HER2 antibodies. We gave her chemo for 3 months and then just continued her. And 3 years later, she's in remission. So patients even with stage 4 disease and good treatment are living a long life. She recently went to her son in Hamburg, spent a month with him and came back. So it's not only a long life, it is also a good quality of life, which is what we aim for as oncologists. And now we've gone a step further. We're able to attach the chemo onto the antibody. So the antibody targets the cell receptor. The chemo and the antibody are taken inside. The chemo is released inside and given to that cell. So this is how far we've got, and they are available here. I thought I'll spend a few minutes on young women with breast cancer. So why is the incidence increasing in India? We're seeing a lot of women below 40. So we have a younger population. We have non-communicable diseases. We have changing social and cultural practices. Women are going to office, they're highly educated, they're not getting married early, and they're not breastfeeding. And they have definitely an increased calorie intake and reduced physical activity. So this is the most important. So I would encourage you to talk to your young women who come to you for any problem and tell them that lifestyle is very important in preventing breast cancer. The unique challenges in delivering cancer care is that you don't really suspect it. When a young woman comes with a breast lump, you'll say it's mastitis, you'll say it's a fibroadenoma. Nobody's going to think of breast cancer. So there's a low suspicion. Genetics plays an important role in young women. Some of these are unmarried. So I recently had a 23-year-old unmarried girl with breast cancer. Then I had a 25-year-old who had just been married for a year, no children. see these oncofertility issues, she definitely wants children after her breast cancer treatment, and how can we maintain her fertility? Then of course body image, families, work-life balance, and the worst part is younger women have a worse prognosis. You can see the red line below in all those survival curves. Those are the young women, they do much worse. Alright, so just remember, for stage, young women do worse than their older counterparts. So we get a lot of triple negative in these patients. These patients get into denial, they don't take their treatment, they delay their diagnosis, they say can't be happening to me. So we go through a lot of these social issues in the clinic. Fertility is huge. We are seeing a lot of women who are taking, we advise when they are diagnosed, we do advise embryo cryopreservation, and we do the random start approach where we don't have to wait for the cycle, and we do give them hormones and then do the oocyte retrieval. So we have to tie up with IVF experts for this, and we are referring patients more and more. Chemotherapy is reversible in most organs, the damage, but not in the ovaries. So the older the patient is, the more likely she is to have post-chemotherapy damage in the ovary due to chemotherapy, and unlikely to gain fertility or even menstruation. So that is something to be watchful about. And of course the age. So in her, after 35, the ovarian reserve is gone. You give them chemotherapy, there is no chance that they are going to get pregnant after that. Type of chemo, so we give alkylating agents which are highly toxic to the ovaries, the dose, then of course even anthracyclines. And very few patients with breast cancer ultimately get pregnant, and the rate, you can see all the cancers, and what is left is the rate lower than the general population. All cancers have a lower pregnancy rate as compared to the general population. And the more to the left the line is, the worse the chances. So if you look at breast, it's really quite sad. It's quite to your left, the bottommost line that you see. Right? So this is the line that you see. Is it safe for the mother? Pregnancy after breast cancer? So many of my gynec colleagues ask me, ma'am, this patient has finished chemotherapy, radiation. Now is it safe for her to conceive? Yes, there's good data that in fact in some cases pregnancy after breast cancer can even give a better prognosis. So it's not harmful. You can allow these women to get pregnant. And the problem is, can you interrupt the treatment? Because if they are on tamoxifen, that is harmful for the fetus, so they can't conceive while on tamoxifen. So we've got recent trial results presented last December at an American conference telling us that a young woman who wants to conceive and needs tamoxifen can take her tamoxifen for 2 years, take a break for 2 to 3 years, conceive, deliver the baby, and get back on tamoxifen. And her survival is the same. So it's very reassuring for patients of ours to have this knowledge and do this procedure. Oncofertility counseling is important, there's not always available. These are the different strategies for preserving fertility, and the simplest one is to give the GnRH analog injection before the chemo every month during the chemo and after the chemo. It doesn't always help, but if you look at the premature ovarian insufficiency rate, it is reduced with giving GnRH, and the pregnancy rate is doubled. So this is what the data shows. It has some benefit in these patients. But it also depends on what the partner wants. I recently had a patient who we are treating. She's 33, they've had one child, but their second baby died at 10 days, so it's a very emotional issue. And she's come with breast cancer, and she was hoping she could have a second child. And I told her at 33, her ovarian reserve is not going to be very good. So we had a heart-to-heart conversation, and ultimately they realized, we'll do the GnRH, we'll try for a baby later, but we won't compromise her care. The patient's life is more important. So if you talk to the patient, they do understand that one kid is enough, one healthy child is enough. You don't have to go crazy and focus more on getting well. So last bit is ovarian cancer. We are seeing a lot more ovarian cancer in our country. I really can't understand why we are seeing a lot more endometrial cancer in our country as well. And ovarian cancer is the third most common cancer amongst women in India. And again, the mortality is 2/3 of those diagnosed. 75% of women diagnosed with ovarian cancer are stage 3 and 4. And after surgery and chemotherapy, almost all patients will relapse by 5 years. So every year, 10 to 20% of them will relapse. And we need to give them something after the chemo to keep them on maintenance to reduce and lengthen this period where they are disease-free. Now, I'll end with hereditary breast ovarian cancer syndrome. This is common. Don't ignore it. Always ask for a family history. But despite family history being positive, 5 to 10% of ovarian and breast cancer are hereditary. The BRCA gene is passed from either the father or the mother to the patient. So these are the two main genes, and they can make up almost half of all ovarian cancer cases. And the discovery of the BRCA gene was by a very amazing lady called Marie Claire King. This was way back in 1974. And do you know, she was a mathematician. She was a statistician who joined the health services. And by studying hereditary families, she started collecting all these families where there was a inherited breast ovarian cancer. So she started thinking there could be a genetic cause. And she's the one who discovered the BRCA1 gene. Then there was another company called Myriad who was also working on the same thing in another part. And they beat her to cloning the gene before her by a few months. But she's credited with the discovery. And the prevention is very important in those who are carrying the gene but don't yet have breast and ovarian cancer. And this is the general population risk. With BRCA1, 50 to 80% lifetime risk of developing breast, ovarian 20 to 40%, prostate, pancreatic, and many others. So this is what we do in the clinic when the patient comes. You can see the red arrow. So this lady has found out she's got a sister who's BRCA1. So the round circles are the ladies and the squares are the men. And the line is where the patient is diseased due to the disorder. So what you can see how the inheritance is. Every generation has patients. This is autosomal dominant, where every generation there is an equal chance, men and women getting the gene. There's a 50% chance. So this lady who's 40, who's got tested because her sister and then her aunt, her paternal aunt and her maternal aunt have both been diagnosed with breast and ovary. She's very worried. She comes to you and says, what should I do? So she's what we call a carrier, okay, of the gene. So you have to take a good history. And nowadays, we offer them options. So let's go a step further. We are all not Angelina Jolie. We are not living in the US, all right? So the story of Angelina Jolie is that her mother was diagnosed with ovarian cancer. Mother was found to be positive for the BRCA1 gene. Angelina Jolie got tested because she wanted to know if she's a carrier. Unfortunately, she tested positive for the BRCA1 gene. So what does she do? She undergoes a bilateral prophylactic mastectomy, right? And then a year or two later, undergoes a bilateral salpingo for it. So she's reduced her chance of breast cancer completely, okay? And she's reduced her chance of ovarian cancer. And you have to remove the fallopian tubes because that's where the origin is. Okay, it's not just good enough to do a oophorectomy. So what happens in the US? People have gone crazy. Whether they are BRCA1 positive or negative, everybody wants bilateral mastectomies. So this was the wrong message and fear that she created. And they said that women demanding mastectomies went up 4 times. And there the surgeons had a problem convincing a normal woman without a BRCA mutation to have a normal one-sided surgery. Because they all insisted they wanted to be like Angelina Jolie, remove everything. So this extent of panic is also not required. Our country culturally, bilateral prophylactic mastectomy is a lot to handle. But the good news is you can do the salpingo oophorectomy and you get a 40% risk reduction for the breast cancer as well. So you buy time. So a woman finishes her childbearing and then you can go step by step. You can also advise carrier surveillance, where you can do every 6 months an MRI of the breast or mammo. It is safe radiation-wise, and it creates, a lot of reassurance in these women. And now, why am I talking of BRCA? BRCA is a tumor suppressor gene. It helps you and me to repair damaged DNA, all right? But now, we have drugs for these patients, and that has been our biggest achievement. So I'll just bother you for 3 minutes more, okay? So pay a little attention. This is your double-stranded DNA. This is when there's damage, it breaks, radiation, something. Normally BRCA runs, BRCA1 and BRCA2. The proteins run and repair it very nicely, and the cell is happy, everything is continuing. Now, look at a situation where the BRCA is completely gone, right? So there is a damage to the DNA, double strand, both the strands are gone. This is now repaired by an polymerase enzyme called PARP. Okay, but it's not repaired properly. Little bit here, there, error-prone repair, but nevertheless, we make do with it and the cell survives. Not brilliantly, but it survives. So now, in a patient with no BRCA is missing, we block the polymerase enzyme with a tablet, right? So now, this can't be repaired by double strand, okay? And single strand also gone. So that faulty repair mechanism gone, the cell dies. So we actually have these tablets available and we are using for our women in the clinic. Now you'll ask me, are they expensive? That's the first question. So now good news is we're making them in India. So the cost has come down substantially and it is affordable and life-saving for a lot of these patients. What am I showing you? The blue line is those who have received the drug and the red line is those who have not received the drug. And look at the survival. Look at the difference in the survival. So that arrow that I've shown you is the magnitude of benefit. So there's definitely a benefit. So the take-home messages from my talk is that breast cancer is a growing problem and the most common type of cancer in India today. We now give chemo upfront or antibodies upfront for most breast tumors so that we can give risk-adapted therapy for what is remaining afterwards. We have new targeted antibodies and these are keeping stage 4 patients alive and for many years. A large number of breast cancers in India are young, below 40. They have different characteristics of disease and they have special needs like fertility. The incidence of ovarian cancer is rising. It is third most common in India. And BRCA testing or genetic testing is very important for all women with ovarian and young women with breast cancer. It has implications for the family, we talked about carriers, and for effective treatment options like the PARP inhibitors I showed you. So thank you very much for your attention. Any questions? Yes.
Ma'am, what is the cause you think for the young girls to get CA breast 23, 25 years?
So the most important cause.
No, your thoughts. Not about lifestyle or this thing. Your thoughts.
My thoughts for 23, 25 is so there are a handful of patients, as Dr. asked, that come when they are 23 and 25, and all the ones that I have treated in my practice, they've had a hereditary basis. Yes.
Ma'am, what will be the best tool for screening for ovarian cancer? As you said, it is the third most commonest cancer.
Unfortunately, we'll be coming to that in our case presentation. There is yet no effective screening tool for ovarian. You have to have a high degree of suspicion. I mean, you know the symptom triad that we look for, but every woman can have indigestion. Every woman can have, frequency of urination. So I think a high degree of suspicion and even transvaginal ultrasound, CA125, these are not good methods that we are using. So I think Dr. Joy will cover this in detail later. Yes?
Along with lifestyle, how much promiscuity is changing the incidence of cancer?
Can you repeat that, please?
Promiscuity in women.
Yes.
How is it changing the percentage of the cancer?
So promiscuity is a very big factor for cervical cancer, ma'am. And when you have multiple sexual partners, your incidence of HPV infection or human papilloma virus infection and exposure to the virus increases greatly. So it is an important factor in cervical cancer, but not so important in the others. I think we'll straight away go on to the next session. So I invite Dr. Rahul Kulkarni, who's our moderator for the breast cases, to come and take over.
So good morning everyone, and thank you all of you for gathering in such a huge numbers. That really shows how much interest you all have developed in oncology. And again at the outset I would like to thank Dr. Shonanath Madam for setting such a good context for today's meeting. And as you all know, the theme for today's meeting is case-based discussions. So we all have tried to keep the interaction as much as possible and keep it less theoretical and more practical. So the first session for today's meeting is on breast cancer. So I will be moderating this case-based discussion based on breast cancer. And for that I would like to invite our expert panelist, Dr. Shonanath Madam is already there. I would like to invite Dr. Joy Ghosh, who is our oncosurgeon at Sahyadri Hospitals, Pune. Dr. Sammil Upadhyay, he is a radiation oncologist at Sahyadri Hospitals, Pune. Dr. Rahul Dakesh sir, he is the head histopathology department, Sahyadri Hospitals, Pune. And Dr. Gayatri Achyutan, she is a radiologist at Sahyadri Hospitals, Pune. So we all have just now seen the context for today's discussion. The breast cancer, as we all know, is the most common cancer now in females as well as in India. So without wasting much time, we will directly jump to the case discussions. But I thought that before going to the case-based discussion, let us first set a context of how do we approach any breast cancer. This is because whatever cases we are going to see in next few slides, the initial approach to all these cases is similar. So first we'll try to see how do we approach a patient when it comes to our clinic. So this is a prototype case, a 55 years old female postmenopausal. She is diabetic, hypertensive, and on treatment. She presents with a left-sided breast lump since about 2 months. On examination, she has around 2 by 2 centimeters firm to hard lump in the left upper outer quadrant of the breast. The nipple areola complex is normal. And on examination, clinical examination, there is no obvious palpable axillary lymphadenopathy. So let me ask first to Dr. Joy. Dr. Joy, these kind of cases are commonly seen and presented to surgeons. So when you see such case, what will be your next first investigation?
So we can see that the age group is of an elderly lady, beyond 55, and also the clinically, when you examine the patient, you can see that there is a firm to hard lump, even though it is small in size. So always in the back of your mind, the suspicion has to be that this could be a malignant tumor, and you have to evaluate in that way. Many of us jump into doing FNAC immediately, thinking that it is an OPD procedure, so like it's FNAC cover. But that's not the way actually. The recommended technique is to first do an imaging and characterize this lesion. So the imaging in the first step usually consists of a sonography and a mammography done combined together. So many people do only one of the things, only sonography or only mammography, but that's not the correct method. Both have to be combined because both will give different ideas about the lump and give us a characterization of that lesion, whatever it might be.
So Dr. Gayatri, can you just give more insights about which patients need a mammography and which patients need a sonography, or for which patients will offer a sonography more than a mammography?
So all elderly patients above 40 years of age should definitely get a mammography done, and
Yes.
along with the mammography we have to get a correlative ultrasound of the breast as well as both the axilla. If a patient is very young, maybe less than 30 years of age, then we can initially go for a sonography, and if at all we find a suspicion of malignancy or anything like a calcification we want to look for, or BCIS we want to look for, then we can do a mammography along with it. And if a patient is presenting with a hard palpable lump like this, then we have to do both mammography and sonography.
So especially in patients who are young, like 30 years of age, we do a sonography because all these patients are generally tend to have a dense breast. So we may miss initial few things on mammography. So obviously sonography has to be done first. So on mammography, what type of classification do you give in the reporting, which helps the clinical oncologist to define the further plan?
We give the BI-RADS classification for
Okay.
mammography.
So this is the BI-RADS classification. You all will be reading this BI-RADS classification whenever you will be seeing the mammography. So this helps us to understand what is the likelihood of that mass which is palpable or which is seen. If the reporting is BI-RADS 0 to 3, it is most likely to be benign, so we are not that much worried. But especially if it is mentioned that it is BI-RADS 4 or BI-RADS 5, it has to be taken seriously, it should not be neglected, and it has to be proven by next investigations. So Dr. Joy, again coming back to you, the mammography shows that it is suspicious. So what will be your next step? Will you go ahead with the FNSE or will you do something else?
So if the tumor whatever the lesion comes out to be a BI-RADS 4 or a BI-RADS 5, 5 is very suspicious that it could be cancer, and 4 is also quite suspicious. In that also we have an A, B and C category which categorizes as per the findings. So in that 4C and 5 very highly suspicious it could be cancer, and 4A, 4B require evaluation with a sampling. This sampling we always prefer that we do a core biopsy or a true cut biopsy as compared to an FNAC. Yes, if you don't have a facility for a true cut, you can do an FNAC, that's okay. But the information provided with an FNAC or the false negative rate with an FNAC is very high. It is not acceptable to miss a diagnosis when the cancer is there and then assure the patient ki kai nahi hai, and you go home and then the patient comes back with an advanced cancer. So a biopsy has a very high specificity and sensitivity. It will detect it and as well as provide certain other information which helps us guide the treatment ahead. So I think we'll cover that.
So in any case, will you do a directly incisional or excisional biopsy? If you do a FNAC, if it turns out to be negative, will you do a excisional biopsy directly?
Right, so as I said, FNAC has a chance of being negative, falsely negative. So only FNAC is not guiding us ki now next do the lump excision. The true cut biopsy has a very good chance of getting the diagnosis, and it is also like a needle biopsy. It is just a small needle, slightly bigger than the FNAC needle, and that needle can give us pieces of the tissue which are then frozen, fixed in paraffin, like how a histopathology is done. The same way the pathologist will examine it and give us the information that yes, the diagnosis is confirmed. So we don't need to go ahead directly for an excision if the FNAC is negative. A true cut biopsy is also an OPD procedure. It is done hardly in 5-10 minutes. Patient can go home immediately. It's a very simple thing to do, and the diagnosis is as good as doing an excision also.
So that is very important because we do see such kind of things happening very routinely. Like the patients initially undergo FNAC which is not showing a conclusive report and they directly undergo a excision, and that not only creates a problem in the further plan, but that is ideally not required as well. So the biopsy, whatever you have done, confirms a malignancy or invasive carcinoma. Now again, Dr. Joy, would you directly go for a surgery in such kind of patient based on a clinical examination, or you would like to have any further radiological investigations before you go for surgery?
Yes, so in this matter we decide regarding the findings in the patient. So there are some factors which will tell us that this patient has a higher chance of having a metastatic disease or having a spread of the cancer, secondaries in some other place. And in this situation, you would want to investigate ki before you offer any kind of surgical treatment, you want to investigate whether the cancer has spread or no. Especially with larger tumor size, skin is involved, you have that pudor orange appearance on the skin, multiple nodes are involved. So these patients have a high risk of having a possibility of spread. And they require scanning, either with a CT scan or a PET scan before you offer any kind of surgery. In early breast cancer, where the tumor is very small, like in this lady for example, just 2 centimeters, nodes are negative. So you don't need to do CT scans and PET scans for such patients because the chances of having a spread is very less. But a basic minimum investigation such as a sonography of the abdomen and a chest X-ray is also good enough in these patients to stage them. So early breast cancer and locally advanced breast cancer, different staging for them.
Right. So it is must that we do some sort of staging investigation before directly jumping to surgery, even if we feel clinically that it is a early breast cancer. Now again, is a biopsy and a staging sufficient before going to the surgery? Dr. Shonana ma'am, I would like to ask you, even if the patient looks operable, would you like to do some additional test on the biopsy before offering the patient a surgery?
So I think it's very, very important to get a IHC test or a receptor test. There are 3 tests called estrogen receptor, progesterone receptor and HER2 receptor, which classify our tumor into 3 different subtypes. And treatment is actually dependent, adjuvant treatment, whether to give chemo upfront for shrinkage, all these are dependent on these results. The Ki67 is nothing but a proliferative marker, and if the tumor is ER/PR/HER2 negative or HER2 positive, then the Ki67 will automatically be higher and will tell you that the tumor is proliferating at a rapid rate. Sometimes in HER2 you get results like 0, 1 plus, 2 plus and 3 plus. 3 plus is a positive HER2 result. 1 plus and 0 are negative HER2 results. But 2 plus is neither negative or positive, it is equivocal. Of these, 25% are actually HER2 positive. So HER2 testing is looking at the protein by this method. What you want to look at it is the gene. So for the gene, we do a test called FISH, which is fluorescent in situ hybridization. This takes a turnaround time of about 5 days, but it's important because it tells you whether the patient is HER2 positive, which it will be in 25% of cases, or HER2 negative, which it will be in 75% of cases. So these tests give you a lot of information as to how is this patient going to behave, what is going to be her future prognosis, what kind of treatment will she respond to best, and do I do surgery upfront or do I give some chemotherapy to shrink the disease? So these are very, very important tests to be done.
Right. So in today's era, these testing on the biopsy before the treatment planning is must. So that is equally important. I would like to ask Dr. Rahul Dake sir, our histopathology head. Sir, how do we actually perform these tests in the routine clinical practice, and what is the relevance? What are the chances of variations which we can get in such kind of tests?
Okay, so ER/PR, HER2 and Ki67, they are the IHC test, immunohistochemistry test. So there are multiple steps. We take an antibody. That antibody binds to the specific receptor on the cell. So ER, first picture is of ER and it shows brown color. So external receptors are present on nucleus. That antibody binds to the nucleus and we can see that brownish color. The very important factor, that is pre-analytic factor for IHC is fixation, formalin fixation. If it is a 6-hour fixation in neutral buffered formalin, very specifically neutral buffered formalin, the fixation will be ideal. And if it is ideal, then these tests will give best result. Any compromise in the fixation will compromise the expression of this marker. Suppose the fixation is not good, HER2 may turn out to be negative. So even though we have tissue, we have diagnosis, but the fixation is not good, it will affect the receptor status and it will affect the result. Ultimately, it will affect the patient's treatment. So pre-analytic factors is a huge, we can say prerequisite for good IHC results.
Correct. So important point to note here is that just doing the test is not important. It is also important to do these tests at a very good accredited labs and reliable labs. We have seen there is a variation in some patients where the treatment plan entirely changes because of the factors which Dr. Rahul sir had just mentioned. So it is important that we get these tests done at reliable centers also. So as Dr. Rahul sir has mentioned, that estrogen receptors, they are not only prognostic but they are predictive of the tumor, predictive of the response to hormonal therapy, and they also tell us that these patients are going to behave in an indolent way and we can plan the treatment. The another important receptor is a HER2 receptor, as Dr. Nag Madam has already told. About 15 to 20% of the patients, they have such kind of overexpression, and because of this the tumor aggressiveness increases, but we have new treatment options for these patients. In some cases where it is equivocal, we confirm it by fluorescent in situ hybridization, and then we can confirm our treatment plan. So based on these, sometimes we have 3 broad specific subgroups of breast cancers: hormone positive, HER2 positive, and triple negative. So you must have understood that just clinically it looks like one simple case, but before treatment planning we all have to do all these tests and also need to define the tumor type before offering the treatment to our patients. So these are broadly 2 main treatment aspects: local treatment, which includes surgery and radiation, and the systemic treatments, which can include chemotherapy, targeted therapy, hormonal therapy, and even immunotherapy. And these are some of the terminologies which we'll be using in the next slides. Adjuvant therapy, it means the treatment which is offered after the definitive therapy, that is surgery. Neoadjuvant therapy, that is whatever treatment is offered before the surgery or the curative intent, and palliative treatment is given to reduce the tumor burden and symptoms. So this is after setting the context. Let us move on to the case scenario. The same case which we saw in the initial discussion, the same female, 55 years old female, postmenopausal, diabetic, hypertensive, a 2 by 2 centimeter lump in the left upper outer quadrant of the breast, BIRATS 4 on mammography, USG guided biopsy confirms the invasive rectal carcinoma grade 2. She is ER/PR strong positive, HER2 is negative, and the staging investigation PET scan shows no distant nodal mets. Now again coming back to Dr. Joy, what next? Now what will be offered to this patient? HER2 negative, ER/PR positive, HER2 negative.
So looking at the tumor size, it seems quite small. In this patient, we would like to offer surgery first because it's an early breast cancer.
Early breast cancer. So what kind of surgery would you like to offer to this patient?
So we discussed the options with the patient. It is no more that mastectomy is the only treatment option, and conservative surgery or breast conservative surgery is also very much available to this kind of patient. We need to examine her breast size, tumor size, the ratio of that, how cosmetically appealing can the surgery outcome be. We are not going to deform the breast after doing a conservative surgery. So all these factors considered, we discuss both the options with the patient. We take their opinion that are you interested in conservative surgery, and if that is possible, we offer it to that patient, explaining that all these patients are going to always, 100% of these cases require radiation again. So without radiation, conservative surgery is not to be done, or not to be advised at least. And mastectomy can be advised in these patients also as per the patient preference. If they wish to, in some patients you can avoid radiation if you do a mastectomy for early cancers. So that may be a factor in discussion while talking to the patient, that radiation is a must for all patients who undergo conservative surgery, and in some patients of mastectomy you can possibly avoid.
So as Dr. Joy rightly mentioned, that complete removal of the breast is no longer the norm. We can also offer breast conservation for patients who are having a small tumors. Now again, as a scenario which we discussed, Dr. Joy, we also see that many of the patients, they come to our clinic with the lumpectomy done outside without a biopsy, and they then turn out to have a carcinoma. So in such patients, this patient does not have any clinically palpable node, or even on a PET scan there is no node. But even after this, do these patients require addressment of the nodes or removal of the axillary nodes?
Yes, so it has been proven time and again that only imaging, sonography, even PET scan is not good enough to judge whether axillary nodal involvement is there, whether the cells have spread to the axillary nodes or not. And hence it is recommended for all cases to stage the axilla by removing some nodes and checking them. Now in this situation, we don't need to always go ahead for axillary clearance. Again, traditionally that is the norm that is followed, the MRM axillary clearance. That is the surgery that we have been taught since we were in college and we were in MBBS. But that is no more the case. For axilla, we can do a simple procedure called sentinel lymph node biopsy. Now this allows us to put a dye in the breast itself. We trace that dye, where in the axilla it is going. We can see it with our eyes if it's a colored dye. There are some specific cameras which are used to look at some fluorescent dyes. Radioactive dyes are also available. So all these can be used to find out which node in the axilla is picking up the dye which came from the breast. And only that node or that group of nodes, 3 or 4 nodes, can be removed and checked. And we have Dr. Dhake and pathology colleagues who will examine that node immediately during the surgery. They will do a frozen section. They will tell us immediately whether it is positive or negative. If it is negative, there is no further surgery required for the axilla. A clearance is not required. And why this is important is because it drastically reduces the chances of developing lymphedema or the arm swelling, which is very common after axillary surgery. So this is the technique that we use for every patient who is clinically node negative, and this is followed worldwide.
So that is important. If the patient has initially undergone a lumpectomy, he still will require a second surgery. So these patients unnecessarily they have to undergo 2 surgeries. So that can be avoided by avoiding initial just lumpectomy just for diagnostic purpose. So this patient underwent a left BCS, breast conservation surgery, and sentinel lymph node dissection. On final histopath, it came out to be invasive rectal carcinoma. Tumor size on histopath was 2.5 by 2 centimeters. Nodes were negative. So it was a T2N0M0, very early stage breast cancer. Now again comes the $1 million question. So Dr. Nag Madam, I would like to ask, first for the benefit of our audience, can you just enumerate which patients ideally need chemotherapy? All patients who come to us ask, or all patients have a question that really is chemotherapy required. So which patients need chemotherapy?
So I think a simpler way to put it is which patients don't need chemotherapy.
That will come.
Never mind. So usually we start thinking of avoiding chemotherapy in all these 3 different subtypes when the tumor is less than 1 centimeter or when the nodes are negative, right? Now, it's not easy because we spend our whole lifetime trying to decide who needs chemo and who doesn't. But let's go by the subtype. So in a HER2 positive tumor, which makes up 20%, where would I think of giving chemotherapy? So we know that tumors less than 0.5 centimeters have a very low risk of relapse. You could avoid chemo there. But anything more than 0.5 centimeters, some chemo and targeted therapy has to be given. You will laugh and say 0.5 centimeters, why? We have 20-year data to show that these patients can relapse in 2 years and have a 20 to 25% chance of relapse, even with the 0.5 centimeters. So that is the HER2 positive. Let's look at the triple negative. Triple negative, again, you think of chemotherapy at about 0.5 centimeters again. Triple negative are the worst subgroup. They do the worst in spite of chemo, but today we don't have any other weapons. 0.5 to 1 centimeter, think of anthracycline chemotherapy. After 1 centimeter, think of the full 8 cycles with anthracycline and taxane. That is how badly they do, even if they are node negative. Now, those are the easy groups where chemotherapy is clear cut. This is a difficult group. This is a postmenopausal lady with a small tumor of 2.2 centimeters and node negative. Here, if she could afford it, I would do a genomic test for her, but most of our patients can't afford it. That will put her in a low grade, intermediate, and high grade, and my life will be simple. Once the tumor crosses 2 centimeters in a ER positive, I am more likely than not to offer some chemotherapy. But it doesn't have to be 8 cycles. So I would go with 4 cycles of chemo here, which have proved to be beneficial, and then jump her straight onto radiation and hormone treatment.
Correct. So, as Madam rightly mentioned that we don't only look about the tumor size, we look at multiple factors right from the patient's age. So the treatment plan changes even if the patient is young or if the patient is old, based on the various other factors like the Ki67, tumor grade, and the lymph node involvement, and basically the newer one as the gene expressing profiles. Based on that, we do the risk assessment, and based on that, we offer the adjuvant treatment plan. The number of cycles, as Madam rightly mentioned, can vary depending upon the stage and the risk factors. Again, as Madam has already mentioned, can we avoid chemotherapy after surgery? Today it is possible in some selected patients like this patient, which is a very early breast cancer, strong hormone positive, but obviously we need to do a molecular signature testing, that is the Oncotype DX, which is at this point of time is the only recommended test. Unfortunately, the cost of this treatment is around 2 to 2.5 lakhs. So in Indian patients, it is very difficult for us to convince them, and we can actually give chemotherapy at 1/4 of the cost of that the cost of the test. So in some patients we do offer, as Madam said, but for those patients who we offer, we get this kind of recurrence scores, and then only we can reliably say that yes, for the patients who have a low recurrence risk, we can avoid the chemotherapy. We also have some assisting tools which can actually help us to tell what is the actual benefit which we can achieve with the help of chemotherapy. And here also I would like to mention, even if we are getting a 2 to 3% increment with chemotherapy, it appears that it is very numerically small, but it translates into huge number, because saving 3 patients out of 100, you imagine how many breast cancer patients which you are having. Even if you are able to save 3 patients with chemotherapy, we should be offering them chemotherapy, because first chance is always the best chance. Now, Dr. Samit, now I would like to ask you, this patient has undergone surgery and maybe chemotherapy or hormonal based on the testing. Will this patient require radiation?
Yes, sir, absolutely, because the patient has undergone breast conservation surgery. So as Joycer said, initially the patient is already counseled that if they go for a breast conservation surgery, adjuvant radiation absolutely mandatory.
Yes, if this patient would have undergone a MRN, then?
In that case, sir, we would not advise radiation, because the surgery is more complete and it's just T2 and 0.
So what are the indications of adjuvant radiation therapy apart from breast conservation?
Apart from breast conservation, if a node positive disease is there, if we have a large tumor, large initial size, more than 2 centimeters, more than 5 centimeters, node positive cases, in those cases we would like to offer adjuvant treatment.
And anything new treatment techniques have come for radiation?
Yes, sir, absolutely. In these kind of cases where the it is a left-sided cancer, in these cases what we usually do is the patient has good pulmonary function, so they are asked to, we use a technique called DIBH. It's called deep inspiratory breath hold. So what the patient does is she holds the breath in for let's say 15 to 20 seconds. In that moment, the chest wall, it moves away from your heart. So the beams given for the radiation to the left breast, they tend to stay away from the heart, and the dose to the heart is reduced. The machine is automated and the patient can give the feedback. So they have to press a button, take a deep breath. Once they take a deep breath, the machine shows green. We start the radiation. Once they leave the breath, let's say 15-20 seconds, they leave the breath, the machine stops and the cycle continues. It takes a little more time, but it's very much beneficial.
Yeah, so it reduces the chances of cardiac toxicity at the later stages of their life. So these are the newer techniques. Coming to the end of this case, does the treatment end here? Dr. Nag, madam? Many of the times the patients feel that the treatment end here.
No, so I think after this, she needs to go definitely on hormonal therapy.
Correct.
Because she's estrogen receptor positive. We have 2 types of hormonal therapy that we recommend for postmenopausal women. One is tamoxifen, probably the drug that has saved the most lives in breast cancer, and aromatase inhibitors, which are relatively newer, and we choose according to the side effect profile. For example, if a woman has, so aromatase inhibitors have been shown to be 2% superior to tamoxifen in the postmenopausal group. However, if the patient has had a history of fractures, has had very bad bone density or severe osteoporosis, we know that these AIs can accelerate the osteoporosis. So we often start them on tamoxifen, and maybe after 2 years or 3 years of building the bone density, go up to AIs. So this is called a switch approach or a sequential approach. Otherwise, we usually start, if there is no contraindication, aromatase inhibitors. In node negative patients, the recommended duration is 7 to 8 years. In node positive patients, the recommended duration is 10 years.
Okay, so it is very important that these all patients have to be maintained on hormonal therapy. We also again see a lot of patients who just omit the treatment maybe after initial 5 to 6 months because they are told to come back after 6 months and the prescription initially is given for 6 months. They just feel that the treatment is over and they just stop and they again relapse at the later stages of their life. Coming to the last question, ma'am, if in this was a standard protocol which we used to follow till maybe the last year or so. Now, if this patient would have had multiple lymph nodes positive on the panelist profile, would this change your treatment plan today in current 2023 era?
Yes, definitely. So just to tell you that the number of lymph nodes is still the most important prognostic factor in breast cancer. The higher the number of lymph nodes that are positive, the worse the prognosis and the higher the chance of relapse. Relapses in ER positive disease can be of two types. You can get a quick relapse in the first 5 years, or more commonly you get late relapses, which are 8, 10 years and 12 years out. I recently had a lady who's come 8 years after hormonal therapy and she's relapsed in the liver and the lung. So today, for such patients, had she been premenopausal, we would have suggested ovarian suppression, where we would have offered either injectable GnRH analogs, radiated her ovary, or done a bilateral salpingo oophorectomy. However, she is postmenopausal, so there are approaches for her. So the first approach is to add a targeted therapy, which is also oral, to the hormonal therapy. The name of this drug is abemaciclib. It is available in India today. It is recommended for women with tumors more than 5 centimeters or more than or equal to 4 nodes positive, and it has substantially reduced the risk of recurrence. It is to be given for the first 2 years with hormonal therapy. So this is an additional treatment we are offering to our patients with node positive disease.
Correct. So as you've already seen, early breast cancers are highly curable, and though the treatment seems simple, it needs complex decision making at each and every step. So the best outcomes are only achieved after a multidisciplinary treatment approach. And selected patients, we can definitely avoid chemotherapy after proper evaluation and testing. So let's come to the second case scenario. Again, the same patient, 55 years old, diabetic hypertensive, but
I think we've run out of time. You've done such a wonderful job. We are finished now.
So should we discuss one case or?
Let's ask questions now to the audience.
Yeah.
We need some participation.
Any questions? Or you would like to go to the next case quickly? Should we continue? 10 minutes?
10 minutes.
Yeah. So we'll quickly run to the next case. Same case, but she's having a large tumor with a palpable axillary nodes, but this patient is HER2 positive. And on PET scan, it shows right axillary nodes, but no distant mets. So again, Dr. Joy, would you operate her upfront?
This scenario is the other type, the locally advanced breast cancer, in which the tumor is large and multiple lymph nodes are involved in the outside itself. So these patients have a very high chance of having a distant disease also. Even if the scans are negative, there is a possibility that microscopically there may be cancer cells in other organs. So in these cases, we always prefer not to do surgery first, but to downstage the cancer with usually using chemotherapy. And that helps us also do a better surgery in the future. So surgery is there at some point in time, but not in the first sitting.
Correct. So even in these patients who look operable, see, anything can be operated if it can be removed, but these patients are more likely to have a micrometastasis. So all these patients who are having bulky nodes, skin involvement, or patients who desire to have breast conservation, all these patients need a preoperative systemic therapy. These kind of approaches can convert the inoperable tumors into operable. It can facilitate breast conservation, and more importantly, it can give a prognostic information on the response to therapy. That is what we call as pathological response. And Dr. Rahul sir, I would like to ask you to throw some light on pathological response. What do we mean by pathological response or pathological complete response?
So after neoadjuvant chemotherapy, after surgery, we sample the lesion. It may not be visible tumor. It may be fibrous tissue. We'll sample that. will grid it. So one section, 4 to 5 sections. After that grid, it is just like square, and in that we'll see what is the percentage of viable tumor. So under the microscope, it can show fibrosis, it can be necrosis, it can be inflammatory response, macrophages, and tumor. So depending on the percentage of cancerous and non-cancerous part, we'll evaluate the score. And depending on score, we'll say, okay, there are few systems which shows you 1, 2, 3 response depending on the viability of tumor cell. If there is no single tumor cell viable, it's a complete response. And if there is any, it may be single cell, it will be cluster of cell, then it is incomplete response.
Okay, so this pathological complete response has been proven to translate into overall survival. So those patients who achieve this, they are shown to live longer as compared to those who don't achieve this, and also increases the chances of undergoing a breast conservation therapy. So again, this patient deserves a neoadjuvant therapy. Dr. Shunana, I would just like to ask you quickly, which kind of anti-HER2 agents would you like to use in this patient?
So like I said, there are a number of antibodies available for HER2 positive breast cancer, and ideally the best result and the best pathological complete response rate as defined by Dr. Rahul would be with 2 antibodies, pertuzumab and trastuzumab. Now the problem is they are costly, but they are so effective that recently we treated a patient in the same setting, neoadjuvant setting, and after 1 cycle, her tumor is literally gone down by 70%. So we were so scared that it would disappear completely that we had to clip it so that the surgeon later on can actually find that disease. You get very dramatic responses when you use both the antibodies. The rate of pathological complete response with these 2 plus chemotherapy is 70%. In 70% of cases, you won't find any tumor left behind. Whereas if you use only 1 antibody, which is now very affordable, the pathological complete response rate is about 40%. Okay? And it makes a difference to us because then we know who are going to do really well.
Okay. So this is a kind of picture which we can see. As you can see in the PET scan, the tumor is almost disappeared. But even then, these patients will require surgery. Surgery cannot be omitted, and we can really get such kind of wonderful reports on the histopath that there is no viable tumor, and that indirectly increases the chances of overall survival. Now, again, Dr. Samir, will this patient require radiation?
Yes, sir. In view of the large initial disease and heavy nodal positivity, it is better to give radiation to avoid further recurrence.
Okay. Any patient who requires neoadjuvant or who has been given neoadjuvant therapy will require radiation. So that is an important point. It cannot be omitted. And again, does the treatment ends here? No. These patients are HER2 positive, so they will require a maintenance targeted therapy. Ideally, 1 year of maintenance targeted therapy is required, but now we also have some data, especially a data from our own Tata Memorial Hospital, which has shown that those patients who are having a low risk or maybe early HER2 positive breast cancers, we can even shorten the duration to 6 months, but that is must, that cannot be omitted. Again, based on this pathological complete response, we can stratify our treatment as Dr. Nag Madam had already told, that those patients who do not have a pathological complete response, we can switch instead of trastuzumab to the newer anti-HER2 agent, that is Kadcyla TDM1. It is actually a drug antibody drug conjugate which has shown that improves the survival in these kind of bad prognostic subsets. So locally advanced breast cancer should never be operated upfront. Neoadjuvant therapy plus minus targeted is the standard of care, and completing all scheduled chemotherapy cycles before surgery is recommended because we are aiming to achieve pathological complete response, which will help us to stratify our adjuvant treatments. So this is the second case. Third case is very short, just in 2 minutes if I can finish, because that is an important point I think we would like to pass on to our patients. Same patient again, but with multiple skeletal and lung metastasis. The same case scenario. Again, I would like to ask Dr. Joy, would you operate this patient?
So now the answer is completely no, because in this situation the patient is metastatic. We have very significant data which has come from India as well as abroad that there is no benefit in operating patients who are already in distant metastatic sites. Earlier people used to think, yeah, but breast tumor, let's finish it off, and then treat the metastatic sites afterwards with chemo or hormonal or whatever. But comparing both the options, it has been shown clearly that there is no great benefit in operating the breast tumor primarily. As the remaining disease will respond, even this tumor will also respond, and the patient never comes up for surgery in the future.
Yes, so initial notion that all breast cancers, irrespective of metastasis, the primary tumor has to be removed is not true in the current era. This has been proven again by a paper from Tata Memorial Hospital that it does not improve the outcome if we do the surgery in these patients. So only patients who are having excessive fungating mass or bleeding, those patients may be offered toilet mastectomy. But again, on the other context, in some patients who are having only selective 1 or 2 metastasis, maybe in the bones, contiguous areas, or only in a single organ, those patients are called oligometastatic breast cancers. These patients can be offered surgery after initial chemotherapy, after confirming good response, and after multidisciplinary tumor approach. So treatment goals in metastatic breast cancers is palliation and control of tumor burden and maintenance of quality of life. That is most important. Now, how do we decide our treatment in these patients? Again, we do not jump to chemotherapy in these patients. We decide based on the symptoms. If the patients don't have any aggressive symptoms or impending organ failure, we directly switch the patients to hormonal therapy. Now, hormonal therapy again is a very simple therapy which interferes with the cell cycle, because of which these hormones are acting, and we now have multiple drugs which can target these pathways and beautifully reduce the cell cycle proliferation. These you can see the number of agents which are available right now, and we can literally target the cell cycle with the simple oral drug that is called cyclin dependent kinase. Fortunately for us now, these drugs are available at even 3 to 4,000 rupees. So initially 1 year down the line, these were available at 50 or 70,000 rupees per month, but now these have come in purview of the common man. And these kind of responses which we can see only on hormonal therapy, this patient did not receive any chemotherapy, and after 6 months almost the tumor has disappeared. Even in HER2 positive metastatic breast cancers, we give initial small chemotherapy and targeted therapy, but later on these kind of patients can be maintained very well on simple targeted therapies. So these are the newer treatment options in stage 4 breast cancers. Stage 4 breast cancers does not always mean chemotherapy. We have multiple non-chemotherapy options in the form of hormonal therapy and targeted therapy, and it has become a chronic disease now. It's like these patients are surviving for years together, maybe 3 years or 5 years also, and importantly, good treatment, good quality of life is possible in these kind of patients with oral treatments. So next time, if any of your patient stage 4 asks you whether it is worth to take treatment, it is definitely a yes. The take-home message with these discussions is that the newer treatment options for breast cancer have become very safe and effective, and we can offer very good quality of life to our patients. Thank you for your patient hearing.
Thank you, Rahul. That was great. So, are there any questions from the audience?
If there are no questions, we'll move to the
So
next.
we'll move to the next case. May I invite Dr. Tushar Patil to moderate our second case. He's a senior medical oncologist with the Sahyadri Group, and he will be discussing a case of lung cancer.
Good morning, everybody. First of all, I would like to thank the organizers for arranging this Sunday CME on focus specifically on cancer, and that too not a theoretical discussion but a case-based discussion. Just as Madam has rightly pointed out that in the last 30 years, cancer diagnosis and treatment both have made very big strides, be it the identification of the molecular pathogenesis, identification of targeted therapy, improvisation of the chemotherapy, various generations of chemotherapy. And today, half of our patients, as Madam has said, in hormone positive may not even require chemotherapy for a very, very, very long time. They may be just controlled with oral hormonal treatments. Similarly, lung cancer too, there have been multiple what we see as advances, right from the diagnostic part to the surgical part to the radiation techniques to the chemotherapy and the targeted therapy. For this case discussion, I would like to call upon the panelist, Dr. Rahul Kulkarni, medical oncologist at Sahyadri Hospital. Dr. Prasanna Deshmukh is here. He is a medical oncologist at Sahyadri Group of Hospitals. Dr. Joy Ghosh, surgical oncologist at Sahyadri Hospital. Dr. Samat Upadhyay, our radiation oncologist here. Dr. Hasib, our radiologist and intervention radiologist at Secondary Group of Hospitals. Dr. Mihir, our pathologist at Secondary Hospitals. And Dr. Ajinkya, is he there? Yeah. Dr. Ajinkya is our nuclear physician at Secondary Hospitals. Lung cancer worldwide is now accounting for almost 14% of cases. Lung cancer and prostate cancer both 14% each. So at least in males, they comprise a very big chunk of cancers that account for. Unfortunately, even today, lung cancers, almost half of them are getting diagnosed at stage 4 or metastatic stage, where the survival definitely is lesser than the other stages compared. As madam has in the early presentations pointed out, that similarly like for breast cancer, even for lung cancer and prostate cancers, what we are finding is that the age group of our patients is on an average 5 to 7 or almost 10 years younger than the routine population found in the Western countries. In lung cancer, the outcomes have definitely improved even in the metastatic setting. So earlier, where maybe almost 10 years back, when our outcomes were as low as 6-8 months or less than a year, today most of our patients in good general condition to begin with and to not having any critical site metastasis are going beyond 2, 3 and 4 years also, with the advent of various treatments that are available. We just take 3 case scenarios: early lung cancer case, a locally advanced lung cancer, and a metastatic lung cancer case. So, she's a 48-year-old female who's married, no smoking but passive smoking from her son, good performance status, no medical history, came with a mild cough, almost asymptomatic, but had a lesion found on X-ray and then subsequently on a CT scan, which was almost 24 by 15 by 15 mm in size. This was a solitary pulmonary nodule with a cancer probability of 17%. I would like Dr. Joy to address this question: how we approach a patient who comes with minimal or no symptoms and on a scan there is a nodule which is seen with these patients.
So when we encounter such a scan, and it has been happening frequently after COVID era, because many people have undergone CT scans for other purposes and have been found to have such nodules. One has to always remember that ours is a country of tuberculosis. So very, very frequently you will find such nodules of having latent tuberculosis. But also, yes, the chances of malignancy in such cases do exist. And I think I will first pass on the mic to the radiologist, because he is the person who is going to categorize this lesion for me and tell me what are the features which are pointing towards a benign or a malignant pathology.
Dr. Hasib. Yeah.
Okay, so whenever we find a solitary pulmonary nodule on a lung CT done for any reason, so we generally follow what is called as the Practioners Society guidelines. So these guidelines helps us determine which nodule is more likely to be malignant and which is more likely to be benign. So these are based on the size of the nodule, the initial size, the margins of the nodule. Malignant lesions are mostly spiculated, and they tend to have adjacent satellite nodules at some time, and they tend to show prominent spiculations. Another thing is, if the patient has undergone any lung CT in the previous year or in the previous 6 months, it helps us to determine the stability of the lesion. If the size is increasing, compared to the previous scan, if the margins are spiculated, and based on these, and if there are nodes which look suspicious. As sir already pointed out, that tuberculosis is much more common in our country, so we have to look at the possibility of other nodules as well. So if I'm seeing multiple nodules, I'll think in a different way. I won't think in terms of CA lung if I see multiple nodules. But if I see a solitary nodule which is spiculated and which has increased in size compared to the last scan, then definitely I'll be thinking in terms of neoplastic etiology.
I think this has become very important since post-COVID, that we are doing more and more number of scans, and even probably finding early lung cancers which otherwise would have gone undetected and they would have present as metastasis. And the asymptomatic patients where a nodule or a spiculated mass was found, it was biopsied, found to have a malignancy. We had a patient who is 70 years old who was treated for lymphoma 5-7 years back, cured of lymphoma. In the COVID times, he came with breathlessness. He underwent a CT scan. CT scan showed a lung nodule which was around 2.5 centimeters, looked like malignancy. Biopsy proven squamous cell carcinoma. He was also a smoker. So this was the second malignancy that he had. Fortunately for him, there was no involvement of any mediastinal nodes. So he underwent a successful surgery, found out to have a stage 1 disease, and did not require any adjuvant treatment for this. But the same patient, if would have been asymptomatic, he was asymptomatic. Probably if there was no scan done, this was later would have been in a metastatic setting. The PET scan in this patient did show a nodule which was suspected malignant. I would ask Dr. Ajinkya, what is the role of PET scan in the general management of lung cancer day 1 and for follow-ups or maybe response assessments?
Yeah, so according to the NCCN guidelines, PET is recommended for staging purposes in all cases of non-small cell carcinoma and small cell carcinomas. Basically, it helps in to detect the primary lesion staging, that is T staging, then the mediastinal nodal staging, and in detection of distant metastasis sites. Now, for early stages, mediastinal lymph node staging with PET can be tricky because, as said, in our country, like many, due to tuberculosis, prominence or anything, there can be inflammatory nodes. So, whilst doing mediastinal staging in early stages, we have to look for the pattern of mediastinal nodes, whether they are symmetric or not, whether they are asymmetric or towards the side of the primary one. If it is symmetric, it's more likely of an inflammatory etiology, and mediastinal staging is important in early stage cancers. And also PET is also helpful in targeting biopsy sites in initial detection, like at day 1 as Sir said, because it can help to target the most metabolically active tumor part, and can help in differentiation from the solid malignancy from atelectasis or consolidation or necrotic changes. Does help in increasing the diagnostic yield and reducing the number of repeat biopsies or inconclusive biopsies.
So as rightly pointed out, even in early stage or primarily operable lung malignancies, histology proven, probably PET in almost 15 to 20% of the patients will upstage the disease to where we might be having a disease which is occult metastasis, and that is the importance of PET. With this, Dr. Joy, can you answer what would be the workup for a proven malignancy in a very early stage like this? PET did not show any mediastinal nodes, there was no distant metastasis. But what all workup would you need before we opt the patient for surgical intervention?
Yes, so as we discussed, staging is definitely essential. Lung cancers are aggressive cancers. They are known to spread early and fast. Even in small cancers like this, the patient may be unlucky to have distant metastasis. It is possible, it has been seen. So a PET scan is essential. That just doing a CT abdomen thorax like we do in the other tumors is not good enough. It has been shown that PET scan is superior to doing a plain CT scan. So PET scans are required, but we have a disadvantage of a PET scan that the brain is not imaged in a PET scan very well. And because of this, and we know that lung cancers have a tendency to go to the brain. So we always need to do an MRI of the brain separately. So many times we think PET scan and that is the end of it, but that's not the case in CA lung. In lung cancers, we need to do an MRI of the brain to make sure that the brain also doesn't have any deposits, and that is not seen on the PET scan. So for considering staging, this is good enough. This kind of patient with an early cancer with non-metastatic status would usually go in for surgery if that patient is fit. If the patient is fit for a thoracic surgery. So if the patient is fit, the staging and the function, as in the physical function of the patient, is tested with a pulmonary function test, with a cardiac function test. So those are good enough to assess for the patient's operability as well as the metastatic status. On the histopathology, we need a diagnosis confirmation with a biopsy. This is usually done CT scan guided. It cannot be done sonography guided or direct. It has to be done image guided, and the image is usually CT scan. So CT scan guided biopsy will usually give us a diagnosis. Subtyping, as Sir mentioned, some can be squamous carcinomas, some can be adenocarcinomas. So this subtyping, though it is essential in the further treatment, it is not as essential for planning a surgery. Surgery can be done for both subtypes. It is not that one subtype has to be treated in a different way surgically. And the molecular testing that is done is again not essential for the primary treatment, but the follow-up therapy of this patient.
So rightly pointed out, that surgical decisions are based on the PET scan, the MRI brain findings, a bronchoscopy, and in all cases wherever required, a mediastinoscopic evaluation of the mediastinum also, and that would be sufficient. Why is histopathology important? To plan our further treatment. So in terms of what chemotherapy to offer to these patients, whether radiation would be required or not, whether oral targeted therapies would be required or not. So we have moved a huge stride even in lung cancer. 20 years back we were dealing lung cancer as lung cancer only. Today we have in the lung cancer we have a small cell and a non-small cell subset. By and large, non-small cell NSCLC, what we call, is the largest subset. In that also we have something called as a squamous and a non-squamous histology. Dr. Mihir would be able to point out how do these differ.
So the histopathological evaluation of lung tumors has undergone a lot of change since the advent of targeted therapies. So there is a lot of emphasis on tissue preservation now because usually these are core biopsies and small tissue samples. So it is important to preserve as much tissue as possible for further molecular testing. So from that point of view, first and foremost, we should have a good team of technicians, senior technicians who are used to dealing with small biopsies and core biopsies. It is no use if by the time you get the slides for primary diagnosis, there is a lot of tissue wastage. There is no use in that case. So there is a lot of emphasis on tissue preservation. And then for the primary diagnosis of the lung tumor, you have to be very judicious in the use of immunohistochemistry markers because every time you use IHC, there is some loss of tissues. So you have to use an immunohistochemistry panel if required that consists of minimum markers. So earlier we used to classify them as small cell carcinomas and non-small cell carcinomas if the diagnosis of carcinoma was confirmed histologically. But now we have to go one step ahead and further subclassify non-small cell lung carcinomas into adenocarcinomas or squamous cell carcinomas. And for doing this, we have to use as minimum IHC as possible. So usually if morphologically it's a clear-cut adenocarcinoma and imaging also supports that it's a primary lung tumor, then we can just do probably only one immunohistochemistry marker, TTF1, just to confirm the primary origin of the adenocarcinoma and leave it at that. If there is a little doubt, if the tumor is not very well differentiated, if it is moderately differentiated, if there is a doubt that it could be a squamous or adenocarcinoma, or sometimes it is a mixed adenosquamous carcinoma. So in that case, we can maybe use only two markers, one for adenocarcinoma, that is TTF1, one for squamous cell carcinomas, P40, which is in most of the cases sufficient to make a diagnosis. If required, we can maybe use one additional marker called as napsin A, which is another good marker for lung pulmonary primary adenocarcinoma. So the emphasis is on tissue preservation while making a primary diagnosis.
So this is extremely important because lung is also the commonest sites of metastasis, and a metastatic tumor may also present as adenocarcinoma. A primary lung origin will be managed totally differently as compared to a metastasis from a different organ. Would like to ask Dr. Joy here, what would be your surgical approach to a clear-cut operable? Now this is a clear-cut operable patient, and what are the approaches in terms of the surgery that is done? And is there a now minimally invasive available?
Yes, absolutely. So these kind of patients are suitable for surgery looking at the report wise. Then we assess them functionally. How is their effort tolerance? How is their pulmonary function, cardiac function? As I mentioned, one of the patients was 70 years of age. So not always that every patient is going to be fit for surgery, but definitely we need to assess them very thoroughly for the surgery, because surgery provides the best outcomes. Everything else is slightly inferior to surgical outcomes. So surgery for these kind of cancers definitely provides the best outcomes. Another point that I mentioned is that we need to also stage the nodes in the mediastinum invasively. So on PET scan, as he discussed, many of times it can be some TB or something. So on PET scan, we don't always categorize the node as metastatic, even though it might be having uptake, it might be there in a large node. But always we always want to stage these nodes invasively. So mediastinoscopy is performed, which is a procedure done during the surgery. We put in a scope, we sample those nodes, and we check them at the same time and decide whether the nodes are involved or not. And then we proceed for the surgery in uninvolved cases. Surgery for these patients is usually a standard procedure called a lobectomy. So one lobe of the lung which is affected, if the tumor is in the upper lobe, the lower lobe, that lobe has to be removed completely. That is the recommended guideline today. that the entire lobe, even if the tumor is small, it may be a 2 centimeter tumor, but for a complete clearance, the lobe has to be removed. And along with this, we also do a complete clearance of the mediastinal nodes. These procedures were standard as originally done by open surgery, which is a thoracotomy. They used to be painful incisions, and obviously a thoracic incision is going to be more painful than an abdominal incision. So now we have moved completely into minimally invasive techniques called thoracoscopy. The same concept that laparoscopy is performed for the abdomen, such as the laparoscopic cholecystectomy, appendicectomy. The same concept is used in the thorax now, where we make small incisions, hardly 1 centimeter in size, and all those incisions can be used to do the same surgery that we do as open. And the lobectomy, mediastinal node clearance, everything can be done in a minimally invasive technique, which is thoracoscopy or VATS. The common name is VATS.
Right. So I think minimally invasive surgery is the norm wherever applicable. It should be the norm to be followed, and the patient recovery is much faster as compared to open thoracotomy and surgery. So as we see the histopathology here, it's adenocarcinoma T2N1. Though the PET scan did not show any nodes in the mediastinum or in the hilum, but on the histopathology there is a node involvement, and that is the importance of histological, surgical staging for these patients. My next question would be to Dr. Rahul Kulkarni, medical oncology side. What would be the approach after the surgery now that we have found that there is a T2N1 disease which is present for these patients?
Yes, so as Dr. Joy has said, that the first initial approach is surgery, but after surgery, whatever histopath we get, based on that we decide the adjuvant treatment for the patients. So adjuvant treatment consists of chemotherapy with or without radiation. The indication for radiation will be discussing. But any patients who are having a larger size tumor and node positivity, we definitely tend to give adjuvant chemotherapy for these patients. This is to reduce the chances of recurrences. So as we know that patients, even though we have removed whatever is seen, there are micrometastasis which increases chance of recurrence. So these patients definitely need either 4 to 6 cycles of chemotherapy, adjuvant chemotherapy, based on the histopath report. And initially we used to stop at this level if the patient had no distant metastasis. But now, even in these patients who are early, there is an indication that we do some molecular testing, and if these molecular testings like EGFR are positive, we can also offer them adjuvant targeted therapies which can still reduce the chance of recurrences beyond whatever is achieved by chemoradiation.
So definitely rightly pointed out that after the surgery, the chemotherapy decreases the chance of recurrence by a certain percentage, and if we do the molecular testing and the molecular testing is positive for further few mutations, these mutations are now targetable with oral targeted therapies which are given for a certain period of time to further recurrence, decrease the recurrence chance. Even in these stages, when like stage 2 or so, the chance of recurrences are realistically almost 30 to 35% for a lung cancer patient taken over a period of 5 years. I would like to ask Dr. Sampath, is there any role of radiation for such patients early stage but on histopathology T2 and N1 disease?
So according to this histopathology, the patient will not require adjuvant radiation in this case. The only cases which need adjuvant radiation would be incomplete resected, like an R1 resection or a gross residual disease or a margin positive disease, or N2 sometimes can be considered for adjuvant radiation.
So margin positivity, residual disease left behind, or a mediastinal lymph nodal involvement, bulky milky mediastinal on histopathology may be given adjuvant radiation also. So there's definitely this patient received 4 cycles of chemotherapy, and also we put on maintenance. As we can see from this graph, almost all patients after surgical resection would require some or the other form of adjuvant treatment, right? Starting from stage 1B, there would be a role of chemotherapy and targeted therapy, even the early stages. So that's very important to understand that in lung cancer, even in early stages, possibly they will require further adjuvant treatment for prevention of relapse happening. So, yeah. We'll move on to the second case, which is a case of locally advanced non-small cell lung cancer. Again, I would like to ask Dr. Joy here, what would you consider as locally advanced case as per the tumor or the nodal size criteria?
So, when we understand locally advanced, we always obviously consider large tumors. So, tumors which are involving the mediastinal pleura or the parietal pleura. So, we have crossed beyond the boundary of the lung, they have crossed beyond the visceral pleura, and they are involving the parietal or visceral or the mediastinal pleura. Sometimes they are going into the chest wall also, involving the intercostal muscles or the rib cage. some tumors may be involving even the blood vessels. So obviously we know that the major blood vessels are very close by, the aorta, the pulmonary vessels. So if these vessels are also involved by cancer, then they are considered locally advanced because they are not upfront resectable. And along with this, this is the tumor factors. Then we come to the nodal burden. So if the mediastinal lymph nodes are involved in multiple stations, 2 or 3 lymph nodes in different locations, this is also considered a locally advanced cancer. So these are also not upfront operable.
So large tumors with visceral or parietal pleura involvement, vessel involvement, day 1 or vessel encasement, and bulky mediastinal nodes in this patient would classify them as locally advanced. How would the approach be technically different? Dr. Rahul, can you point us out for these patients? Now this patient has a 6.5 centimeter mass with mediastinal lymph nodes involvement. It's a squamous cell carcinoma on histology. MRI did not show any metastasis. PET scan did not show any distant metastasis. So it's still a local or loco-regional disease. No distant metastasis, but different from the previous case where the tumor was just 2 centimeters. Here the tumor is 6.5 centimeters with mediastinal lymph nodes also.
Yes, so this is a locally advanced, it is not operable upfront. So definitely first we will have to discuss this in a multidisciplinary tumor board, whether what kind of approach is feasible later on. So if the oncosurgeon feels that later on maybe if the downstaging helps in tumor removal, we can still think of giving some chemotherapy and assessment. But if upfront it is considered that we are not able to remove the tumor, then the another approach is giving concurrent or definitive chemoradiation. So chemoradiation is almost equivalent to surgery, though not the best option, but whenever surgery is not possible, we can still consider chemoradiation. So in such patients, we decide whether upfront it is possible to encompass the entire mass in the radiation tumor field, or even the radiation oncologist wants a downsizing of the tumor, so which can help them with radiation planning. Based on that, we can decide whether to give some chemotherapy and then definitive radiation or then concurrent chemoradiation.
So in this locally advanced subset, we'll have two different subsets. One is borderline operable, where we would like to do some treatment prior to the surgery, concurrent chemoradiation prior to the surgery, and the other would be a inoperable disease, but still loco-regional, where we would not go for any surgery, but there will be a definitive concurrent chemoradiation which will be given. As we can see, if it's possibly resectable, we will still attempt at shrinking the tumor, as in other cancers that we are doing, and then attempt a resurgery for these patients. Dr. Samad, what would be the role of concurrent radiation in such cases where we want to do the treatment first and then post the patients for surgery?
So in this case, if you want to post the patient later for surgery, the radiation dose will be slightly lower, but it will still help to reduce the primary bulk of the disease, and it will be easier for the surgeon to operate later. In other cases, when it's not going to be feasible for surgery anyway, the radiation and chemotherapy becomes a definitive treatment. So concurrently given radiation and chemotherapy, if we initially feel that the size is too large, the remaining, the normal lump, which will get a lot of dose of radiation because of the initial size of the tumor, we might go ahead with neoadjuvant chemotherapy first and then go ahead with chemo and radiation. But in other cases, we can go ahead with concurrent chemoradiation.
Dr. Prasanna, I would like you to take this question. Is there any role of only chemotherapy as an option, or targeted therapy or immunotherapy as an option prior to surgery or a surgical approach?
So actually, show that when we can use, there is a role of adjuvant immunotherapy, and post that if the patient is operable, then again, yes, neoadjuvant there is a role of immunotherapy, and after that we can continue with the adjuvant immunotherapy for the patient.
So there are multiple treatment options again in this case which are available. One we discussed is concurrent chemoradiation, and then the patient goes for surgery. There are only chemotherapy options also, and there are options of chemotherapy combining with newer agents which are the immunotherapeutic drugs, and which also give a very good shrinkage. And of course this data will be coming up in the next 2 years in a big way, because now we've started recently using these drugs for the shrinkage of the tumor. As this patient did chemotherapy plus the nivolumab, which is the immunotherapy, and as we can see, after 3 cycles of the combination of chemo and the immunotherapy, there was a big reduction seen in the tumor size as well as cavitation happening. That is a lot of necrosis being set in, and this is the what we say as the response that we want for these patients to be able to amenable for the surgical treatment. Dr. Rahul, can you just point out about this drug nivolumab or immunotherapeutic drugs that how we are using in this setting?
So immunotherapy has a different mechanism of action. Like chemotherapy, which we all know that it kills the rapidly growing cells. But immunotherapy, it activates the immune system, the specific cells of immune system that are called as T cells. Now what happens is, whenever there is a cancerous cell growing, generally the human body's immunity tries to kill the abnormal cell or a foreign cell. But especially in cancer cell, there are some receptors which are called as PD-1 receptors. These receptors, they interact with the T cell and they inhibit that T cell. So because of that, the T cell are not able to identify that these cancer cells are actually abnormal and we need to kill it. So that is the reason why cancer keeps on growing in our body. When this was understood, this immunotherapy drug was developed, which is actually an antibody, which goes and binds to the T cell, binds to the tumor cells PD-1 receptor, and that inhibits this interaction. So because of that, the normal T cell will identify that this is an abnormal cell which we have to kill, and it mounts an immune response and it kills the cancer cell. So that is the mechanism, and the initial or first type of immunotherapies which were developed were nivolumab. So this is a type of immunotherapy which was initially developed or tried in melanoma, but after the success in that cancer, it was now tried and found to be successful in almost all types of cancers, and especially in lung cancer.
So immunotherapy in combination or as a single treatment is coming up a big way in various cancers. Especially it is useful in cancers where there is a limited role of chemotherapy, like hepatocellular cancers or renal cancers or melanoma, where chemotherapy hardly plays any role. But of course in other cancers which are chemo responsive like lung cancer also, when combination therapies of chemo and immuno given, the responses are much better. The shrinkage is much better. Our surgical treatment then becomes much more effective, and adjuvant treatment definitely improves the survival in such patients. As we can see, this patient just received the 3 cycles of chemo plus immunotherapy, and there was a fantastic shrinkage for this. Again, I would like to ask Dr. Joy, after this shrinkage, are you happy, and then would you approach this patient surgically?
Yes, I think if the patient is a good surgical candidate, you can go ahead with surgery at this point in time. Surgery, the principles remains the same, lobectomy. If the tumor does involve anything else, like in this case it's not involving the chest wall, for example, or it doesn't involve a particular vessel, but even if it does, we can actually go and resect those sites also. So along with the primary tumor, even the chest wall can be resected. Even the primary, the vessels, for example, a branch of the pulmonary artery, if it is present in the root of the pulmonary artery, you can even remove a segment of the pulmonary artery and reconstruct it. So even this is possible today, and these techniques are very routinely followed to get the best clearance for advanced cancers, so that the patient, you leave them with no microscopic disease inside.
So as we can see that after the surgery, if we see the pathology, there was hardly any tumor in the primary. The primary had no tumor. It was a complete necrosis, though the one node was positive. That was an N1 disease. But definitely this large tumor, 6.5 centimeters, actually showed complete necrosis. Is the beauty of combination of the chemotherapy with the newer agents, that is immunotherapy that we have. And of course this patient then continued to receive the immunotherapy even as an adjuvant treatment. I would like to ask Dr. Rahul, is there a role in this case of adjuvant treatment, and what all adjuvant treatments that we have to prevent a recurrence from happening?
So if the patient has received a neoadjuvant chemotherapy and followed by surgery, then based on the initial responses, generally we don't offer adjuvant chemotherapy if the patient has already received sufficient chemotherapies. Radiation again, depending upon the histopathic report. Initially, that was the end of the treatment, but nowadays with the newer treatment aspects, especially if this patient has had a initial immunotherapy and the patient is PD-L1 positive, so that is the biomarker which we test to assess whether there can be response to immunotherapy. These kind of patients can be offered further with adjuvant immunotherapy, and again they have shown to reduce the chances of recurrences.
So more and more we are going into pre-operative therapy and even the post-operative therapy in the form of either oral targeted therapies or immunotherapy, just to prevent the whatever 10, 20, 30% chance of recurrence. And we've had wonderful results, especially in patients who are receiving concurrent chemoradiation and no surgery. There is a role of immunotherapy as a maintenance both in squamous and adenocarcinomas this maintenance is given up to almost a year's time to prevent a recurrence from happening, and these drugs are working really very well. So our outcomes are much better as compared to what we had 5 or 8 or 10 years back, and they will definitely further improve as we learn how to combine these therapies for the better control of the tumor. With this we come to the last scenario, which is the metastatic case scenario. Lung metastasis, unfortunately even today 50% of our cases present as lung metastasis, where palliation is or palliative treatment is what we can offer to these patients, and there are no curative treatments, barring a few circumstances like only a lung lesion and one single brain lesion, where we may attempt a curative treatment for these patients. So this patient, 46-year-old gentleman who presented with cough, bone pains, X-ray did reveal a right upper zone haziness. PET scan did show 2.2 centimeters in the right upper lung mass with mediastinal nodes. There were multiple bone mets to begin with and also adrenal mets. So these are the favorable sites for lung cancer, bone and adrenals being the most favorite sites for metastasis in such cases. Dr. Prasanna, I would like you to take this case and how you approach this patient.
Sir, radiologically this looks like the patient is having a lung malignancy. So first of all we have to confirm whether it is what is the type of malignancy. So for that we advise the biopsy of the lesion, and along with the biopsy we will also advise if there are any targeted lesions are available or molecular markers testing, that will advise.
As we can see from the picture, the first distinction will be between small cell and non-small cell, and here that we are dealing with non-small cell only. Non-small cell will have a squamous and a non-squamous, that is the histology. Dr. Mihir, what would be the importance of this?
So in a metastatic setting, we always have to be a little more careful, and there should be a strong correlation with imaging findings. So if if a lung tumor is strongly suspecting from imaging, then again we can start, the emphasis should be on tissue preservation here also. So we should start with again a judicious panel of IHC. If it is a clear-cut carcinoma, then you can directly go to specific site-wise immunohistochemistry markers. So the lung tumors, very commonly the adenocarcinomas, they express CK7. And the squamous cell carcinomas, they express P40. So if it is a slightly moderately differentiated or poorly differentiated tumor, you can again put this tumor CK7 and P40. If it is CK7 strongly positive, then again you can use a more specific marker for pulmonary origin like TTF1 or napsin A for confirmation of lung origin. If it is negative for CK7, then yes, then you have to be a little more careful, because majority of the lung adenocarcinomas, they should be CK7 positive. If it is negative, then also other metastasis from some other site should also be in your differential.
Yeah, Dr. Samat, radiation oncologist. This patient is presented with primarily bone pains and some cough. So is there a role of offering palliative treatment in terms of radiation for these patients?
Yes, sir. We can give palliative radiation to the painful bony sites. It will be a short course, 10 days radiation, which will relieve the pain, and eventually the patient can move on to the systemic therapy, which will be the backbone.
Okay, so I think palliation or symptomatic relief is the most important. If the patient is primarily presented with bone pains, and though there is a lot of systemic disease, but symptom relief in form of palliative radiation to the bone becomes an important aspect. In medically also, we start treating them with drugs called as bisphosphonates like zoledronic acid or rank-allyl ligands like denosumab, which are useful in prevention of the skeletal related events and preventing the further fractures. Dr. Rahul, I would like to take you to the question. What is the role of molecular testing in a metastatic lung cancer setting, and how is it relevant today in the management of such cases, lung cancer cases?
So as we saw in breast cancer, in stage 4 breast cancers, we don't directly jump to chemotherapy. The same is the case with lung cancer again, especially in patients who are adenocarcinoma, non-smokers. There is a almost 30 to 40% chance that these patients can harbor some kind of mutation. And initially this journey started with only a single mutation like EGFR, but now we have almost 10 types of mutations which can be possible in these kind of patients, and we really have tablets to target this. So whenever we get these patients after a biopsy, we don't jump to chemotherapy immediately unless there is gross symptoms. We do this molecular testing, this molecular testing nowadays can be done with the very advanced techniques called next generation sequencing. So only in one single test we can get almost all the mutations which can be possible, and based on this mutation which comes, we can offer targeted therapies which are mostly oral targeted therapies to these patients, and they can really have wonderful responses with good quality of life.
So as we can see this slide, earlier this slide only had histopathology as non-small cell and we had only chemotherapy as option. But today, with the advent of the next generation sequencing and something called as broad molecular profiling, we are actually trying to typify the tumor in terms of what the molecular profile is and then give the best treatment available for that particular molecular profile for this patient. There is a EGFR mutation, there is a ALK mutation rearrangement, there is a ROS rearrangement, there is a BRAF mutation, so on and so forth. Each of these has a latest targeted therapy in form of either oral therapies or injectable treatments which are today available, and those patients who do not classify in any of these are the ones who are going to actually need only chemotherapy. So for patients who are relatively asymptomatic, like this patient did not have any symptoms of primary, he had only bone metastasis. We did a biopsy. We are going to send this test for molecular analysis. Meanwhile, we start the palliative radiation. By the time the radiation gets over, which is 2 to 3 weeks period, we'll have this profile ready. If the patient fits into any of these profiles, he goes for an oral targeted therapy or an injectable targeted therapy rather than chemotherapy. Chemotherapy is non-selective, it is little more toxic, and the survivals are not what we say as better with chemotherapy. If the patient has the EGFR mutation and we give that antibody, definitely the survivals are better in these patients with a very good quality of life, with a predictable side effect profile. A home-based treatments which can be monitored every 3 months or every 6 months by doing a scan. So as we can see, there's a huge list. Each of these mutations will have 4, 5, 7 drugs, and not just drugs, there are generations of drugs. Like EGFR mutation, earlier we started with drug called as erlotinib or gefitinib, then came the second line or second generation drugs, afatinib and dacomatinib. Today they are third generation and beyond that generation drugs also, which are much more effective than the first generation medicines, especially when it comes to brain metastasis, treating patients with brain metastasis or prevention of brain metastasis. So there are drugs which are available. There are in each of these mutations we have a drug available. For patients who are PDL1 positive, that is programmed death ligand positivity, there is immunotherapy, and immunotherapy as a single agent or immunotherapy in combination with chemotherapy has proven a boon for these patients. Why so? Because the patients who respond to immunotherapy, almost half of them will become a kind of a long-term responders. So ideal duration of immunotherapy is still either progression or at least for 2 years, and 2 years is not feasible, viable economically for most of the patients, because 2 years therapy of immunotherapy is going to cost somewhere around 60 to 70 lakhs. But we've seen that patients who have taken the immunotherapy for even 6 months, 9 months or maybe 1 year, and if they are responding, even when we stop the immunotherapy, the immune system, because it's activated, continues to respond to the tumor and keeps it suppressed. So our entire aim of doing these treatments and this entire exercise is find out what is best for this patient. Every patient will be different, biological and molecular level, and we need to do this, and for this we need a good tissue diagnosis, a good tissue chunk. So today we are not relying on FNACs, we are doing a lot of guided biopsies where we take adequate sample for immunohistochemistry identification of lung cancer as well as the molecular targets that we can do. If there is a tissue depletion, sometimes we also order a rebiopsy. Dr. Rahul, I would like you to take this question. What is the role of rebiopsy, or what is the role of a liquid biopsy or blood biopsy, blood markers?
So as you have seen that these molecular tests are now extremely important. So we cannot plan the treatment in stage 4 cancers, lung cancers without this. So there is no question that we omit this test. If at all the initial tissue is exhausted with IHC and we are not left with the tissue, and if the lesion is easily accessible or there are some easily accessible lymph nodes where we can easily biopsy it, definitely tissue, again getting a tissue is very important and can be done. But in some patients who are elderly patients whom again repeating a biopsy is difficult, or those who are not willing for a rebiopsy and we still want to find out these mutations, now we have a very good alternative that is called as liquid biopsy. Now liquid biopsy means we just take a blood sample, and from that blood sample we can actually extract the circulating tumor DNA, and on that DNA we can run the sequencing, next generation sequencing, the same test which we run on the tissue, and we can get almost concordant results as we get on the tissue. Though definitely tissue will always be the best, but especially if there is a problem in getting a tissue, we can still find out these mutations, maybe 99% concordance rates, and we can still find out the mutations.
So something called as liquid biopsy or just taking a blood sample, the ctDNA, which is the DNA which is shared from the tumor into the circulation, or cell-free DNA, what we call, it can be quantified in the blood, and we can get the same mutation testing on the blood, and there have been high concordance rates of these ctDNA for various mutations. At least in lung cancer, it has shown very good concordance rates. So we can identify newer mutations. The patient is on a particular drug called as gefetinib, and after 1 year or 2 years, this patient relapses. So we may either do a repeat biopsy from the metastatic site which has progressed, or we do order a blood biopsy which is called liquid biopsy and see for another mutation. If the second mutation, that is T790M, a particular mutation is present, now this patient cannot be given gefetinib. He has to shift it to the third line regimens which are available in terms of oral. Again, these are also oral tablets which are available. So first line, second line, third line, we have these generations of medicines, and patient can still avoid taking any chemotherapy. So cell-free DNA or liquid biopsy is coming up a big way in various cancers, and more so for patients where there is a lot of resistance happening. We also understand the resistance mechanism of various drugs by using this liquid biopsy technique. Someday maybe it will also come in diagnosing cancers. Patient may be asymptomatic. Patient means the person may be asymptomatic, and maybe we will draw blood and find out possibly that this patient is going to develop a cancer in near future or not. So possibly this technique is evolving in a big way, and that's how we are doing. So from a histology of lung cancer to a small cell and non-small cell to non-small cell into squamous and adeno to a molecular level where various mutations are identified, immunotherapeutic targets are identified. We have come a very long way in terms of management of lung cancer patients, and more of precision oncology. That is, the best treatment available to this patient can be given. We need not always go to a blanket treatment of cytotoxic chemotherapy. This chemotherapy will now be reserved mostly in patients who are highly symptomatic, like a patient who is refilling his pleural effusion or constantly coughing, and he needs a treatment to give rapid relief. Then possibly for some time or some cycles we will be able to give the chemotherapy to this patient, identify the molecular targets, and give him the best line of treatment. I think that's the end of our presentation here. We have discussed all the three cases: early, locally advanced, and metastatic. I would like to thank the panelists for the excellent discussion. If you have any questions, we can take it up. With this, we come on to our next case discussion on cervical cancer. The moderator for this session is Dr. Vinod Gore. I would like to call upon Dr. Gore for the further presentations.
Good afternoon. So, now we will discuss regarding the most easiest topic of today. Discussion on carcinoma cervix. We will not have any discussion on molecular biology or different types and targeting therapy. The reason is carcinoma cervix, or majority of the gynecological cancer, we do not have much research. Much data is not available, much research is not available. Carcinoma breast and carcinoma lung are having maximum research in cancer, and we have gone till the molecular level. But gynecological cancer, still we are very, the treatment options are between surgery and radiotherapy only. So I think this is most easiest topic. I would like to call upon the stage Dr. Rahul Kulkarni, Medical Oncologist, Sahyadri Hospital; Dr. Bhushan Balgat, Surgical Oncologist, Sahyadri Hospital; Dr. Maria, Deputy Radiation Oncologist, Sahyadri Hospitals; Dr. Rahul Dhake, Oncopathologist, Sahyadri Hospitals; Dr. Gayatri, Radiologist, Sahyadri Hospital; and Dr. Joy Ghosh, Surgical Oncologist, Sahyadri Hospital. So carcinoma cervix is the most common cancer, second most common cancer of women worldwide, and second most frequent cause of cancer death in women. Persistent HPV infection causes cervical cancer, and subtypes 6, 11, 16 and 18 are positive factors. Risk factors are multiple sexual partners, children at young age, promiscuous sexual behavior, smoker, chronic immunosuppression, HPV subtypes 16, 18, 31 and 32. So this is case 1, 45-year female, history of pervaginal bleeding since 3 months. Pervaginally there is a growth involving cervix. So Bhushan, how will you investigate this patient?
The first and foremost investigation is a clinical examination. After doing a per abdominal examination, the next investigation is a PV and a PR together. So a PV PR examination would give an idea about the growth, if at all it is bleeding or not, the characteristics, whether the cervical os is open or closed. So after having a history and this examination, we can go for a radiological and a histological examination. Which can be, to be specific, a MRI pelvis and a punch biopsy.
Okay. So, as Bhushan said, clinical examination, imaging and tissue diagnosis, these are the 3 things which are required. Now, regarding the imaging, Gayatri, can you tell us which is the best imaging for carcinoma cervix?
Since the soft tissue resolution is best with MRI, CS service would be best staged locally with an MRI of the pelvis. And for the distal metastatic staging, we can use either a PET scan or a CT abdomen pelvis with thorax.
If suppose patient came to me with the CT scan abdomen, would you again like to do MRI pelvis or CT scan is sufficient?
So depending on the stage, if there is bilateral hydronephrosis, if we can see transparametrial invasion, if it's a very bulky tumor, then we may not require an MRI in that case.
Okay, but in which cases with the CT scan, if the patient came with the CT scan, Bhushan, would you like to ask for MRI in any case if the patient came with the CT scan? Gynecologist has already done the CT scan and still you need imaging.
Actually, the best modality, like Dr. Gayatri has said, is MRI. Yes, I would like to have an MRI because even though clinically parametrium can be evaluated, but MRI also gives the additional and a correct information regarding the parametrial involvement. So yes, I would advise MRI pelvis.
Yes, so UAG abdomen, good UAG abdomen, CT scan and MRI all gives good information. MRI is definitely superior and gives better information about the parametrial involvement. And when there is a clear-cut inoperability and patient is having CT scan, there is no need to reorder the MRI. Or if patient is clear-cut operable on the CT scan, there is no need. But if I am little bit having doubt on clinical examination that whether there is a really involvement of the parametrium, I may reorder the MRI. Then second thing is clinical examination. Clinical examination is again the very important part. Dr. Maria, if patient comes with the MRI pelvis and giving you the information that this is stage 2B cervical cancer, would you like to do the clinical examination or you will directly start the radio?
Yes, I would like to do the clinical examination and check the extent of the tumor, check the extent of the vaginal extension of the tumor, because this helps in planning of the further treatment like radiation fit.
Yeah. So clinical examination is very important. Though there is a good imaging with MRI, still that is not the excuse to avoid the clinical examination. All the patients with the carcinoma cervix has to undergo the clinical examination, PR as well as per vaginal examination. Dr. Joy.
Mind about
Yeah.
this clinical
Yeah.
examination part. So very unique thing in this cervical cancers, for example, is that till now we have seen staging T, N, M, and all the kind of staging that we have seen are based on whether the tumor is involving some structure or it has spread to some part or the lymph nodes are involved. The peculiar thing about cervical cancer is that the staging is on clinical examination only. It is not based on any imaging. So it is the surgeon or the whoever, the oncologist who examines the patient and decides the stage of the cancer as per the examination. If it is operable, stage 1, A, B. If it is not operable, whether it is 2B, 3, all these are decided based on staging on clinical examination primarily, and imaging is used as an adjunct to confirm the staging. So staging for cervical cancer is actually a clinical staging, it is not an imaging staging.
Yeah, so that was the actual point for asking this question, because clinical examination is very, very important in carcinoma cervix. Many times even medical oncologists may not like to do the clinical staging. Surgical oncologists usually do the clinical staging frequently. So you should get the clinical staging done by your surgical oncologist colleague, preferably, and you should do the PR as well as PV. And many times superficial vaginal involvement, these findings you may not see in the MRI properly. So clinical staging before starting any treatment is very, very important, and we should not miss on that, because many times we order PET CT, MRI, CT scan, and when patient comes to us afterwards, we do not have any information about clinical staging. So clinical staging has to be done. Then third part before deciding treatment is tissue diagnosis. So Dr. Rahul, which are the means of doing tissue diagnosis in the carcinoma cervix? Dr. Rahul.
So for carcinoma cervix, better accessible site is to have punch biopsy, and it should be deeper, because most of the time, depending on the, we can say, biopsy size, it may vary, because we can get only carcinoma in situ. If there is no deeper tissue, then it will be carcinoma in situ. So if we have deeper tissue, then we can commit it is carcinoma. So adequacy of tissue along with the deeper chunk of biopsy is important.
So Bhushan, if suppose gynecologist has sent you the patient with MRI, and rather than doing biopsy, she has done a pap smear. Now pap smear is showing carcinoma in situ. It is stage 1A carcinoma cervix. Would you like to repeat the biopsy, or you will operate the patient depending on the pap smear finding?
So pap smear is basically used for screening purposes, and a punch biopsy is a diagnostic test for proceeding for oncological management. So yes, I would advise also a biopsy even though a pap smear has been done.
Yeah, so many times we get the patient where pap smear is already done and it is showing high grade changes or carcinoma in situ, but we should repeat the biopsy. So biopsy is required. Dr. Rahul, can you put light on this pap smear screening, various findings of the pap smear, and can you add at the same time on the treatments for that stages? Because this is very common. Many patient comes with the pap smear, and that pap smear interpretation is very difficult. Many people don't understand what to do for that stage. So can you explain in detail that various findings of the pap smear and treatment for that stage?
So actually, for cervical cancer screening, pap smear is the only thing we have right now in hand. We have to start pap screening say by age of 21, and ideal frequency is 3 yearly pap smear till age of 65. If we are doing pap smear along with HPV testing, then the frequency can be 5 years. 5 yearly we can do it. So in pap smear we evaluate the cytological atypia. So NILM is normal cells, there is no atypia. Ascus is some atypia is there, but it is not sufficient to call it as a malignant. Then comes LCIL, low grade dysplasia, and then comes HSIL. So for Ascus, it can be because of inflammatory atypia. So we can just follow for 6 months. We can take care of inflammation, and then we can repeat it if it is Ascus. For LCIL, we can again follow up the patient. So follow up 6 yearly, take care of infection, it's okay. But the moment there is high grade atypia, we have to go for colposcopy. LCIL along with HPV positive, HSIL, we have to go for colposcopy. On colposcopy, you can detect the area by that acetic acid, acetabulate area, take the biopsy, and in the biopsy, then we can see whether it is a CIN2, CIN3 or CIN1. So depending on the cytological atypia, we have to go for next investigation. And better to do pap smear by liquid-based cytology.
Yeah.
Because in conventional there are many artifacts. Inflammation is there, mucin is there, crushing of cells, air drying of cells if they are not fixed properly. So going by liquid-based cytology, it gives a good amount of viability of cell. It could preserve the morphology of cell. And for diagnosis, it gives a single line examination, single layer examination. So morphological details in liquid-based cytology is far better as compared to conventional cytology. One more advantage of liquid-based cytology is we can use same sample for HPV testing. For conventional, if 2 smear, 1 smear, we cannot go for HPV. But if there is any positive finding in pap smear by liquid-based cytology, we can take that sample for HPV testing.
Okay, thank you. Can you tell how liquid-based cytology is taken? How sample is taken?
So I think surgical colleague will be explaining it better.
Joy, can you add?
Most of the practicing so I think they know. But basically it has to be done under good speculum examination. You have to visualize the external walls and of the cervix. You have to take the sample with the brush or the cyto brush which is provided or the spatula, and then you're given a different sort of container. Earlier we used to just spread the cells on the slide. It used to be either alcohol fixed or air dried, and then we would send it in the Coppix jar to the examination. But now it is given in a very separately provided container, and the cells are placed in that container. The brush is placed in that container, which is sent to the pathological examination.
Okay. So this is all about screening and pap smear. Dr. Rahul Kulkarni, at the same time, we will, before going to the detailed treatment of this case, can you put some light on this HPV infection and vaccines? Because that is also very important part in carcinoma cervix. So can you tell us when to give this HPV vaccine, which are the people in population in which this vaccine is given, and when this vaccine is given?
So, as in the introductory slide, sir has mentioned that the most common cause of cervical cancer in India and all over the world is human papillomavirus. Almost more than 95% of these cases, they are actually contributed because of HPV infection. So initially we did not have any measure for that, but now we have a vaccine. A vaccine is a thing which is given to prevent the infection. So that is the reason why we have to give this vaccine before we acquire this HPV infection. So the rationale for that, and because of this, the age group for which it is recommended is between 10 to 12 years. The purpose or the understanding is that HPV infection is acquired most commonly by the sexual route. So before the individual has its first sexual exposure, that is where they have the most likelihood chance that they can acquire HPV. And once they acquire HPV, the vaccine will not do anything. So for that purpose, you have to target the age group, both males as well as girls. It's not only for females; it is only for it's also for boys also. So both boys and girls from 10 to 12 years of age are the ideal age group for giving HPV vaccines. It is generally given in 2 doses, 6 months apart, and some patients the age group can be extended up to 26 years. But that is after the discussion with your gynecologist or your oncologist. Especially if there is no history of sexual exposure or unmarried people, they can just extend it. But this is the age group where it is generally recommended.
Oh, thank you. So we have done the imaging. There is a 2 centimeter growth involving cervix. Vagina is free. Bilateral parametrium is free. Uterus is free. Rectum is free. Bladder is free. Before that, I would like to ask this question to Gayatri. Which are the things actually you mention in the report of the MRI when we do it for carcinoma cervix? Which are actually the things which are important for surgeon as well as radiotherapist to take the decision about the treatment? Because many times we order the imaging and the important things are not mentioned in that.
So whenever the patient comes for local staging of CA cervix on MRI, we have to look at the tumor size. That is the most important thing.
Yeah.
It has to be measured in all 3 dimensions, and we have to look at the involvement of vagina, whether the upper 1/3 of vagina is involved, lower 2/3 is involved or not. Then we look at the parametrium, both the sides, whether it is only substandard, whether there is any soft tissue bulging into the parametrium, whether there is frank inflammation or not. Then once the parametrium is seen, we look at the ureters on both sides and vesico-ureteral junctions and whether there are any back pressure changes secondary to it. Then we look at the adjacent structures, that is urinary bladder and rectum, most importantly, and the pelvic side walls and bones.
Yeah. So these are the actually things which actually your radiologist should mention, and while ordering the imaging, you write up. Kindly kindly mention about the status of bladder, ureter, rectum, and parametry. Because if your radiologist doesn't mention about all these things, and many times radiologists are insisting on MRI, and I cannot read MRI properly. So I many times rely on their report. So it is better my radiologist writes everything about the surrounding structure. So all the structures are free. There is a 2 centimeter growth involving cervix. So Dr. Bhushan, what will be your treatment of choice in this patient?
Sir, the management for a 2 centimeter tumor which is not involving the parametrium or the vagina would be a type B modified radical hysterectomy. In simple terms, we call it as Wertheim cystectomy. So I would counsel the patient that radiation is also an option for it, but surgery would be better because it's in the stage 1B1.
Okay. Dr. Maria, do you agree with him, or you would like to give radiation to this patient? He is a squamous cell carcinoma.
Yes, radiation is an option. Concurrent chemo and radiation is an option in this case, even in 1B1. But if the surgery and radiation both gives equal results, but in early 1B1 case, surgery is usually preferred option.
Okay, but both gives equal result. But still, you would like to send the patient for surgery, right?
We have to talk with the patient, and based on the patient's decision, we can either go for concurrent chemo radiation or surgery.
Yes. So both the options are available. Particularly when patient is unfit for surgery, then when we will send for radiation. Otherwise, operable patient will operate. So, any role of evaluation under anesthesia, Dr. Jha? Not in this patient, but which are the patient in which you would like to do the evaluation under general anesthesia?
Mainly in patients, first of all, for a biopsy, sometimes we require it. I mean, not all biopsies can be performed in the OPD. Sometimes it can be really painful, and the patient will not allow you to do that biopsy in the OPD. We need to do the biopsy under anesthesia, spinal anesthesia or GA. Sometimes for examination, findings to be confirmed. So, for example, if the growth is slightly bulky, patient is not very cooperative in the OPD, has a lot of pain related to the disease. In those situations, if we need to really stage the disease properly, then sometimes we need to do this examination under anesthesia when the patient is under spinal or GA, when pain factor is removed completely. And this examination will allow us to judge whether a parameter involvement is really there or no. If we have a doubt, sometimes what may happen due to a growth having an infection, there may be superadded infection. That also causes indulation in that area. So we give a course of antibiotics, and we really want to judge whether this parameter is free or involved. So such cases, we may plan that, okay, you take antibiotics for 7 days and we'll do an examination or an EUA at a later date, and then we'll decide whether the parameter is really free or not. And that gives us a judgment whether this patient is a surgical candidate or not.
Yeah, so if you are doubtful about your PRPV staging, and if you feel that I am not able to conclude whether parametrium is really involved or not, then evaluation under anesthesia is a choice. Now, Dr. Bhushan, would you like to do laparoscopic surgery for this patient or open surgery?
Before 2018, I would have preferred a laparoscopic radical hysterectomy, but after the LACC trial, although laparoscopy is now in the newer trials is showing good results than open, which will be published soon, but at present today I will go for an open radical hysterectomy.
Okay. Right.
So laparoscopy, the only benefit is the incisions. The benefit of laparoscopy is smaller incision, hence lesser pain and better wound healing. But actually inside the abdomen, the surgery has to be the same. Whether you do it open or you do it laparoscopically, the surgery has to be identical in both. Now what was found in some data which was published few years back, and they did a large number of patients they compared laparoscopy versus open, and they found that the outcomes of laparoscopy were slightly inferior compared to open. And this is the first time in the history of cancer surgery that this has happened, that they have found that laparoscopic surgery is slightly inferior to open surgery. Now this has raised a lot of debate actually, because that is one group of people who had published this data, and still a lot of examination is going on as to why this happened, because it has not been replicated. It's not happened in the other cancers. We do rectal cancer surgery, colon cancer surgery, laparoscopically every day. We do thoracoscopic surgery. So this is a very unusual thing to find, that experienced surgeons had lower or inferior outcomes just by doing laparoscopy. So as of now, we've taken a back foot. We don't do laparoscopic Wertheim gastrectomy anymore. And if the data comes up in the future that it is safe, it may again go back to that. But as of now, the standard guideline is to do open surgery for CA surgeons.
Yeah, so at present, actually, this is one malignancy where laparoscopic surgery, at least at present, is showing inferior results. So at present, we are not supposed to do the laparoscopic radical hysterectomies. At present, we have to stick to the open radical hysterectomies till the new data comes. If new data comes and which shows equal results, then we can go for laparoscopic surgery. But at present, data is suggesting that you should do the open surgeries. Now the situation, suppose Bhushan has operated one patient, same patient, histopathy is showing 2 by 2 centimeter lesion, parametrium free, vagina free, 0 out of 25 lymph nodes, no lymphovascular emuli or perineural invasion. Dr. Rahul Kulkarni, would you like to do any adjuvant treatment in this patient?
So as far as the medical oncology is concerned or chemotherapy is concerned, there is no adjuvant treatment required for this patient. There are selected cases which require adjuvant radiation, and that depends upon the service criteria which the radiation oncologist will try to see, and based on the histopathological examinations, they take a call whether adjuvant radiation is required, but no adjuvant chemotherapy for this case.
Yeah, Dr. Maria.
So adjuvant radiation, the indication for adjuvant radiation is based on some criteria which tells us the risk of recurrence, like Sibley's criteria, in which we see the tumor size if it is more than 4 centimeter. Then cervical stroma invasion if it is more than 1/3, and lymphovascular invasion. So if these 3 are positive, then there is an indication of adjuvant radiation, and in this case there is no indication as there is no LBCI positive. And chemo is required or not is based on another 3 criteria, which is parametrial invasion is there or not, positive nodes or positive margins. So that in such cases we give chemotherapy along with radiation.
So for this patient, no adjuvant treatment required. It is early squamous cell carcinoma. Now the similar patient is operated by Joy, and that patient is showing different histopath. There is a 2 by 2 centimeter lesion, but 2 out of 20 lymph nodes positive, perineural invasion present, lymphovascular emboli present. So Dr. Maria, adjuvant treatment for this patient.
In this case, I would like to give radiation as well as chemo post surgery, because as there are risk factors which tells us there are high chance of recurrence in this case if no adjuvant is given.
Okay. So Dr. Rahul, this is only chemoradiotherapy or you will give adjuvant chemotherapy also?
No, as per whatever current literature is available, there is no role of adjuvant chemotherapy as such. Whatever treatment we give is along with radiation. So the main treatments in cervical cancer, as sir had rightly pointed out in the beginning, is surgery and radiation. So these 2 options are curative. Chemotherapy is just to support the 2 treatment options. So whenever these patients require adjuvant treatment, mainly they will require radiation, that is to prevent the local recurrences. And whenever there are more high-risk features like node positivity or lymphovascular invasion or parametric invasion, these patients are high chance of having the recurrence, and so we need to little bit boost more the effect of radiation, and for that we give chemotherapy. It is not to reduce the size or anything, it is just to improve the effect of radiation, and that is called as concurrent chemotherapy. It is given every weekly along with radiation, that is to boost the effect of radiation.
So which are the situations in the carcinoma cervix where pure chemotherapy has a role? Not as along with the radiotherapy, but only chemotherapy as a treatment modality. Which are those situations in the carcinoma cervix?
If the patient is upfront metastatic, Like
Yeah.
you find that the patient is having a local mass, but on investigations you find out that the patients are having a lung mets or liver mets. So there is no question of giving a definitive local surgery or radiation. So in those patients, only option which is left is systemic treatment in the form of chemotherapy or maybe other forms of treatment which are available. The other unique cases where there is a very huge mass and there is a heavy para-aortic nodal burden, and these patients are definitely not going to be a surgical candidate. But if you are going to treat them with the radiation, definitive chemoradiation, in selected patients, those patients can have a initial neoadjuvant chemotherapy to downstage the tumor and the nodal disease, and followed by chemoradiation.
Yeah, so chemotherapy actually has very limited role in the carcinoma cervix. Only situations are metastatic disease or disease paratic disease out of the field radiation field out of the radiation field disease. Then we downstage and then give chemoradiotherapy. And third thing is if the patient is having large bulky mass involving the mucosa of the bladder. In those patients we cannot give directly radiotherapy because there are chances of fistula. In those cases also we downstage with the chemotherapy. Now another case. This is a 45-year female, 8 by 8 centimeter growth arising from the vagina, arising from the cervix, bulging into the vagina. On imaging there is a compression of ureters. Para is free but tethered. Biopsy is adenocarcinoma. So now, Dr. Joy, would your line of treatment change?
Yes, so this is a very large tumor.
Yeah.
Definitely does not qualify for a surgical candidate.
Yeah.
We have got the biopsy as adenocarcinoma. Para tethering, I would give it the benefit of doubt to the radiation oncologist and tell that the para is involved. And such a case would definitely go ahead for definitive chemo-RT if distant sites are negative. But no surgery in this kind of patient.
Okay. Maria, would you like to radiate this patient? 8 by 8 centimeter large tumor.
Yes, but before going ahead with the definitive treatment, I would like to do the CT and check whether there is hydronephrosis or
There is no hydronephrosis. There is only just a compression of ureters. There is no involvement.
Yes, I will go ahead with current chemotherapy.
Okay. Rahul, would you like to give neoadjuvant chemotherapy in this patient?
See, basically there is no proven role as such for neoadjuvant chemotherapy. As we have said, there is a limited role for chemotherapy in patients with cervical cancer, but these kind of decisions have to be taken in a multidisciplinary tumor board. So again, the main treatment is going to be radiation. If our radiation colleagues feel that the tumor is very large and it is difficult for them to encompass the entire tumor with proper margins in the safe radiation field, only then and then we would like to consider these patients for neoadjuvant chemotherapy. Another point is that this patient is adenocarcinoma. So adenocarcinoma is a little bit worse prognostic subset as compared to squamous cell carcinoma of the cervix. In such patients, selectively, maybe we can give chemotherapy initially to just 1 or 2 cycles to just downstage the tumor and also help the radiation oncologist to improve the radiation field. But as a norm, not all patients will like to give neoadjuvant.
Yeah, actually the purpose of putting this case is the same, which Rahul has rightly pointed out. There is a role of multidisciplinary tumor board. This type of cases requires decision by group of people. One person cannot take decision. The reason is, now whatever the trials in the carcinoma cervix are there, they are about the squamous cell carcinoma. There is no subset analysis. So we don't know the treatment of adenocarcinoma cervix. There is no clear-cut guideline for particularly adenocarcinoma cervix. Now there are two thoughts or two groups. One group feels that there are trials which includes cervix adenocarcinoma as well as squamous cell carcinoma. So you have to treat the patient as per the guidelines of the carcinoma cervix. Other group says that, see, this is not the squamous cell carcinoma. It is right that squamous cell carcinoma responds to radiotherapy, but adenocarcinoma doesn't respond to radiotherapy. So you cannot give radiotherapy to this patient because they will not respond. Dr. Maria, have you seen 8 by 8 centimeter tumor responding to radiotherapy? It is very less likely, right?
Definitely, it responds to radiotherapy as adenocarcinoma, considering the histology. after giving the external radiation, there might be, we have to boost it with brachytherapy definitely, but
Sure.
it does respond to it.
Yeah, but there are less chances. So these are the patients in which actually you should discuss with your medical oncologist, you should discuss with your radiation oncologist, and you have to take decision as per that case. So many times we give even neoadjuvant chemotherapy because there is no negative data also that giving neoadjuvant chemotherapy in adenocarcinoma cervix have negative effects. Such type of data is also not there. So you can give neoadjuvant chemotherapy, downstage the tumor. After downstaging, if that patient becomes operable, Dr. Bhushan, would you like to operate?
To be frank, no sir, I would, after neoadjuvant, I would refer it for CTRT, that is
Okay.
concurrent chemoradiotherapy, rather than going for surgery.
Okay, Dr. Joy, this patient now has 2 by 2 centimeter residual tumor, parametrium free, bladder rectum free. Would you like to operate? Yeah, Rahul has given neoadjuvant chemotherapy. Now patient is came for re-evaluation to you, and it has a very good response to chemo. Just 2 by 2 centimeter tumor, clear cut operable.
Yeah, so this was a concept which was followed earlier, that the thought process was that if the tumor is only locally large, it's not invading the surrounding structures, that you can reduce the size with chemo and then you can offer surgery for them. But again, we have Indian data coming from Tata Hospital, Bombay, that this approach is not good enough.
But that is for adeno or scams. Again, the question is.
Again, it's a mixture of mixture of histologies. Obviously, squamous is more prevalent in that.
Yeah.
But neoadjuvant chemo, again, followed by surgery, has not shown to be beneficial compared to doing CTRT.
Yeah, but again the debate is that trial also has 90% patient squamous cell carcinoma. So that data is also for squamous cell carcinoma.
So everywhere, all cervix, the percentage of adenocarcinoma is always smaller compared to squamous.
So you would also like to send the patient for CTRT?
Yes, because there is no obvious advantage to doing surgery in this.
Okay. So these are the various situations how we get patient, but it is not like that we get patient with 2 by 2 centimeter and then we take the surgical decision. Many times we have to take decision in very difficult situation. For example, suppose this is the same patient, 2 by 2 centimeter tumor, squamous cell carcinoma, and laparoscopic hysterectomy is done by a gynecologist. So Dr. Bhushan, what we will do now? Patient is having 2 by 2 centimeter tumor on MRI, operated by a gynecologist by laparoscopic simple hysterectomy, and now patient came to you. Now patient is saying now my histopath report shows squamous cell carcinoma and it is a cancer, and I have come to you for further treatment.
So what is done is done. Laparoscopy has been done, so we cannot revert it.
Yeah.
So we would now go look at the histopath report and go for adjuvant treatment if required any. No other surgical intervention can be done recently in the immediate post-op.
Okay. Joy, would you like to restage or do any surgical intervention in this patient? Simple hysterectomy, 2 by 2 centimeter tumor, you don't know about the nodal status. Now, post surgery, there are enlarged lymph nodes, 1.5 centimeter bilaterally.
So it's a very difficult scenario because already a hysterectomy has been performed, and by immediately after surgery a lot of adhesions form. People have tried doing a re-surgery there, as in converting a simple hysterectomy into a radical or a Werthian hysterectomy by removing the parametrial tissues. But it is extremely difficult in an operated setting. You may end up damaging the ureter, the bladder, the rectum, because everything is fibrous, everything is stuck there. The nodes which are enlarged might be inflammatory due to the surgery which has happened in the near past. So it's not possible to comment on the nodes just on imaging. So more or less these patients who are operated in this manner eventually are going to require radiation for benefit of their disease control, and probably it's not going to be very beneficial to do a resurgery in them, because most of these patients will end up going for radiation because of incomplete staging or something or the other, some factor or the other. So probably not the best option to offer a resurgery in these cases, because anyways they will be requiring radiation in the future again.
Okay. Dr. Maria, would you like to radiate this patient directly?
Yes, I
Because he has not taken any surgical opinion. Patient has directly came to you. So would you like to take surgical opinion, or you will directly radiate this patient?
I would directly go with radiation, and as node is in this case node is positive, so definitely this case goes to stage 3C. So concurrent.
The node is not positive. See, they have operated. So post surgery there are enlarged lymph nodes. Now even PET CT is showing that increased uptake in those lymph nodes. So we don't know whether these nodes are positive or not.
Sir, based on the histopathology, we definitely know the size of the tumor and extension. So, according to me, concurrent chemoradiation will do the good job, and will get the similar outcome. And as it is already operated, I think surgeon will be difficult.
Yeah. So actually, again, the purpose of putting this case is it is not like 2+2 in the practice or taking decision in the oncology. Many times it requires a lot of discussion between your colleagues, your team. So very important part of the cancer treatment is having the discussion amongst medical oncologists, radiation oncologists, surgical oncologists, and pathologists, radiologists, and then many times we discuss about the PET CT scan in such patients with the nuclear medicine physician, that whether he feels that nodes are positive or not. So after discussing, then only we will take decision. I will personally, many times I see when nodes are positive, they doesn't respond very well to radiotherapy. So
From stage 2B to 4 onwards, the standard of care treatment for CSFS is concurrent chemoradiation. So in this case, if patient has been already operated before, definitely they will require radiation.
yeah. So again, another purpose of putting this case, Dr. Rahul Kulkarni. Now, anyway, the second case was having node positive. I have operated, and again after surgery, I have sent for radiotherapy. My gynecologist colleague has done simple hysterectomy, and again that patient is going for chemoradiotherapy. So what is the difference? So patient is anyway requiring radiotherapy. So does it make difference that I have done radical hysterectomy and gynecologist has done simple hysterectomy?
Main thing is that if you have done an adequate surgery, you may have avoided radiation. Like in the first case, you have seen that there was no indication for radiation. It was a simple 2 centimeter tumor, there was no high risk features. But here, because the completion surgery or completion staging has not been done, even though there are ambiguous findings on the radiology or on the CT scan or the PET scan, we are still not sure whether going inside and removing the tumor, whether that is going to be negative or positive. And if it is going to be positive, again the patient is going to be subjected for radiation. So in that case, giving the benefit of doubt, because of the ambiguity, we may avoid the second surgery and give the concurrent chemoradiation, because that will save one extra modality of resurgery. But the purpose is that the first and foremost surgery has to be the most complete surgery that will help the patient to achieve the best outcomes in minimum modality of treatment.
Yes. So actually, many times people ask, okay, what difference it makes whether I do the simple hysterectomy or even in the carcinoma ovary. Many people says ki, what is difference if I have not done omentectomy or peritoneal biopsy? But if you have done complete staging and nodes are negative, you can avoid the radiotherapy. So you can avoid the side effects of radiotherapy. So you can avoid one complete treatment. And second thing is, it has an effect on prognosis. You doing simple hysterectomy and giving radiotherapy, and you are doing radical hysterectomy and giving radiotherapy, prognosis will be definitely different. So it is not like that ki, you can do the simple hysterectomy and send the patient for radiotherapy. So these are the various situations.
Here I think main difference what in the situations that you pointed out is that in these two situations, the first one, we are giving radiation to cover up for incomplete surgery.
Yeah.
In the second one, we are giving radiation for high risk factors to prevent a recurrence in that patient, because that patient has certain high risk factors. But in the first situation, if the surgery was probably performed in the correct manner, it would have probably avoided radiation or anything. We are giving the radiation to cover up for an incomplete surgery in that patient. So it's a different situation altogether.
That's why side effects also increase and prognosis may be little bit inferior. So these are the various situations we come across, and this case is regarding advanced malignancy. You would have made any carcinoma cervix which is beyond the operable limit, we always offer chemoradiotherapy. Do you agree? There is no any other treatment modality.
Standard of care in all the patients from 1B3 onwards to stage 4.
Any contraindication to radiotherapy? So I have to ask that because all patients, hardly 10% patient with the carcinoma cervix comes to surgery. So almost 90% patient goes to radiotherapy. So is there any contraindication for radiotherapy in carcinoma cervix?
There are as such no contraindications, definitive contraindications for radiotherapy only in early stages where fertility sparing is required. In such cases, we can offer the patient surgery like radical trachelectomy or colonization.
Okay, and if the bladder is involved, including the mucosa, still you will radiate directly?
Yes,
or
even
rectum,
in stage 4A.
rectum mucosa is involved. So would you like to advise anything?
Again, I think this becomes a multidisciplinary tumor board situation, because again we are dealing with a very, very advanced cancer. That patient is having involvement of the bladder, is involvement of the rectum. For our staging purposes, cystoscopy or endoscopy is performed, and we prove that the mucosa is involved. Now these patients, even though as per the guidelines are actually treatable with definitive radiation, we know that there is a high chance of developing fistulas because there is a through and through involvement of the next organ. So in such situation, you really have to be very, very careful in deciding the treatment and counseling the patient and the relatives that what is the future expected from the treatment. It is not just blanket advising a treatment for them and do this as per the guidelines, do it. It has to be an individual patient-based approach.
So these are the some situations, bladder is involved, rectum is involved. Then again, radiation oncologist has to discuss with his surgical colleague, and sometimes we do the colostomy, divergent stoma, or sometimes if bladder mucosa is involved, we give neoadjuvant chemotherapy and then radiotherapy. So these are, we have to take the decision according to patient. So this is about carcinoma cervix. Now actually madam has requested, so one more patient we will discuss for 5 minutes. Dr. Gayatri, patient presented with 5 by 5 centimeter cervical lymph node. FNAC shows squamous cell carcinoma. How will you investigate this patient?
5 by 5 centimeter cervical lymph node, which is metastatic.
Metastatic.
So we need to evaluate for the oral cavity and the...
So this cervix is cervical is neck. Actually, Dr. Nag madam requested me to present one at least patient from the oral cavity because there are surgeons and ENT surgeons also in the audience. So 5 by 5 centimeter cervical lymph node.
So we need to look for the primary, using an MRI of the head and neck, and most often we will do a CT also to look for any.
Dr. Bhushan, how will you investigate this patient with the just patient presented with the cervical lymph node 4 by 4 centimeter?
3 types of investigations will have to be done. One will be a triple scopy, that is a bronchoscopy, esophagoscopy, and endoscopy, the nasal endoscopy. After doing a scopy, if we find a primary, we go according to the primary management. If we do not find a primary, also we have to go for a radiological investigation, which will be a CT scan from the skull base up to the thorax. And third investigation will be a histological investigation that will, instead of going for a FNAC, I would prefer a two-cut biopsy of that patient with the IHC. If at all I don't find a primary. If it's clear-cut primary is there and I get a biopsy, IHC usually will not be required because we know the primary. But if there is no primary, I would go for a biopsy and a IHC both of them.
Okay, Dr. Rahul, if FNAC done outside is showing squamous cell carcinoma, still you would advise biopsy or IHC in this patient, or FNAC squamous cell carcinoma is sufficient?
Okay, so FNAC have a few challenges. If it is poorly differentiated squamous cell carcinoma, the pathologist cannot differentiate between the squamous versus any other. Poor differentiated, because there is no differentiation, no keratin, no squamous cell. But if it is showing frank squamous cells, straight away I can commit it as a squamous cell carcinoma. So depending on the morphology, I have to take call whether to call it as squamous upfront or to add a biopsy.
Okay. So it depends. Usually we send it to pathologist. If Rahul calls me and tells he biopsy is required, I will do biopsy. If he says ISC is required, then I will send ISC. So it is the confidence of my pathologist. If he says that further testing is required, then we send the further test.
So because FNHC is only cytological diagnosis here. So it's an architectural diagnosis. You can say ki, if there is blue cells, blue looking cells, small cells, many other differentials are there. Small round cell blue cell tumor. So it can be lymphoma. It can be small cell carcinoma. It can be anything. It can be sarcoma. So depending on the morphology of the cells under that smear, then diagnosis changes. So if I am not sure if there is no squamous cell, I will ask for biopsy, and on biopsy if it is squamous, well and good. If it is not, we will go for ISC.
Yeah. So if it is clear-cut squamous cell carcinoma, not much further investigation is required. But if my FNEC or biopsy shows poorly differentiated carcinoma or poorly differentiated tumor malignancy, then we need a immunohistochemistry to differentiate between adenocarcinoma, lymphoma or squamous cell carcinoma. It can be squamous cell carcinoma, it can be adenocarcinoma from lung or breast, or it can be just a lymphoma. So we have to differentiate. Then we have done the PET CT of this patient, and PET CT is not showing any primary. There is only single lymph node, and it is squamous cell carcinoma. So how will you plan the treatment of this patient?
Unknown primary with squamous cell carcinoma, you expect the primary to be like a hidden primary in the head neck region only. So possibly in the nasal cavity or in the oropharynx or in the hypopharynx. So in such situations, the treatment is again given by definitive chemoradiation. You cover the head neck fields, entire portals are covered, both neck sides are covered. After chemoradiation, you assess the response with a PET scan again after 3 months and see what is the residual remaining. Some patients, selected cases, if there are residual tumors remaining, you can offer them surgery specific to that site. So that is how the treatment is for the unknown primary injury.
Okay. Bhushan, if it is a 2 by 2 centimeter lymph node and you want to do the surgery, you will do only lymph node dissection, lymph node excision, or complete lymph node dissection of that neck?
A complete modified radical neck dissection will be done because of we need to evaluate all the nodes, and we need to take care of the whole template in the neck rather than going only for the excision biopsy of the single nodes.
Okay. And Dr. Maria, how will you plan the radiation for this patient?
So radiation is planned according to which level of cervical lymph node is involved. So initially, if level 2 cervical lymph node is involved, so based on the potential sites, primary sites, we treat the primary sites with a low dose of radiation. For example, if it is level 2, we usually include oropharynx, nasopharynx, and if 1B is there, submandibular lymph node, then we include tongue. So based on the level of lymph node, and then we include the whole neck in the radiation field, and the node positive side is given higher dose.
Okay. So maximum area from base skull to the carina is involved, is covered in the radiation field, and they give the more dose to the side of the involvement and for potential sites. So this is all about carcinoma cervix and cervical malignancy. If you have any question, you can ask. Okay, so no questions. So we will move to next presentation. It is case discussion on ovarian cancer by Dr. Joy Ghosh, surgical oncologist.
Good afternoon, everyone. I must thank you for still being here. I think, but we are coming to the end of the session, so this is the last case discussion panel that we have. I think the previous one was quite illuminating and very interesting. So I'd like to invite my panelists. So Dr. Rahul Kulkarni, because Dr. Srinivas is not available with us today, please join us on the stage. Dr. Bhushan Balgat, Dr. Vinod Gore, our surgical oncologist, Dr. Gayatri, radiologist, and Dr. Mihir, who's a pathologist. So we'll be discussing just two cases of ovarian cancer and two scenarios, the same way that we've done, one early, one advanced, and we'll go through the just the points which we discuss during our planning for treatment for these cases. So the first patient is a 55-year-old lady, nothing, no comorbidities, and she just presents with a vague history of abdominal fullness since 6 months. No other complaints physically, and somebody examined her and said, okay, you get a sonography done. On the sonography, it's showing a 17 by 12 centimeter solid cystic mass in the pelvis. Obviously, with such a big mass, they are not able to visualize anything else, no other details in the pelvic cavity. The bladder is obviously compressed, and no other significant lymphadenopathy. So I'd like to ask Dr. Bhushan. Now, this patient comes to you with this kind of a sonography finding. So what would be your next approach for this case, like the next investigation that you would advise for this patient?
Two kinds of investigation I would like to advise. One will be the contrast enhanced CT scan of the abdomen and pelvis to see for the organ of origin. Although it has been given clearly in UAG, I would like to have a confirmatory evidence on a CT scan. Also the extent of the tumor, or whether it's more likely malignant or benign. And the second type of investigation is the tumor marker, which specific. It's not very specific for a malignant tumor of the ovary, but for any ovarian tumors, you would like to do a CA-125 together with the CT.
Sure. Dr. Gayatri, okay, we have advised a CT scan, and now it is much easier for you to tell what's happening. But on the sonography, what are the challenges that you face when doing a sonography of a patient like this? As in, obviously, our decision has to be based on the report the radiologist gives. So, what are the challenges faced by radiologists when dealing with such a large complex mass in the abdomen?
So since it's a very large mass, then it is difficult for us to determine the organ of origin. And a transvaginal ultrasound would have definitely helped in this case to look for the other ovary, the normal ovary would have we need to assess for the solid components and the vascularity within the solid components, look for internal septations, how thick the septations are, whether there are any lymph nodes, although the retrobacterium may be obscured because of the large mass and the bowel which is displaced. But we have to at least try and look for retrobacterial lymphadenopathy, liver lesions.
So, I think all these points that ma'am mentioned is points that you have to ask the radiologist when they're giving you the report. That tell me about 1, 2, 3, 4, 5. That are these things there? What is the findings that are there on the mass? Solid component means how much? What is the amount of septae inside? Have you done a TVS to look for the other ovary? So these help you guide the patient as well. That what is the further step and how to counsel the patient in case that yes, there is a risk that you may be having. Nobody wants to listen to this diagnosis that this may be a malignant tumor. They are always looking for the opposite. So you have to know certain findings from a radiology report which help you tell the patient or counsel the patient that this is what we are looking at. So then we come to the CT scan. Dr. Gayatri, what do you think about this scan? What do you think that this tumor is represented?
So there is a large solid cystic mass. It's a complex.
Madam, we cannot hear you.
So there is a large solid cystic mass which is occupying the lower abdomen. There are enhancing internal septations within the mass and enhancing solid components as well. The lesion is reaching almost up to the anterior abdominal wall and displacing the bowel loop. So we need to look at the rest of the images from the series to see if the organ of origin is ovary. We can even trace the ovarian vessels and see if it is leading to the mass. We can look for the opposite ovary, whether it is normal or not. And we need to look at the omentum to look for any omentum nodularity, fat stamping or other deposits, and for metastatic cells.
Right. So this gives us a fair idea as to what we are looking at. So Dr. Gayatri, can you tell us whether we can assess operability looking at just the CT scan, or do we need any other investigation, or CT scan is good enough to assess operability for this kind of a tumor? It's a huge tumor in the abdomen. Can we assess operability via CT scan? Okay, Dr. Bhushan, you can take the question. No problem.
Yeah, so the operability depends in case of CA ovary. Only three things would defer me from going for surgery. That is a hilum involvement, base of mesentery involvement, and if there are so many deposits in the serosa that intestine of such extent has to be removed that the patient will not have a good intestinal function.
So that is basically advanced ovarian cancer. So as Dr. Bhushan said, we will be doing tumor markers in these patients. Now generally we don't prefer to do only a CA125 report because that is a specific marker for ovarian cancer. We are well aware of it. We also prefer doing the other tumor markers. Sometimes, as sir mentioned in the previous case, that a lymph node in the neck could be a primary from anywhere. And we have seen this happen in other cases also. Lung tumors, they can be primary which have some other primary which has had a lung metastasis. So the ovary also can be a metastatic lesion. It can also be a metastatic deposit, can be a Krukenberg's, which is coming from some other primary in the abdomen. So this is always essential that before we offer this patient any kind of definitive treatment, we rule out that this is definitely an ovarian primary and not something from the bowel, gallbladder, stomach, something else. So these tumor markers are a simple thing which you can do in the initial assessment and they will help you guide the further plan of this patient. Any other investigation, Dr. Bhushan?
PET scan would be required obviously before we go for any surgical intervention. Also it will tell about peritoneal deposits. There are two investigations to talk about peritoneal deposits. One is PET and the other is staging laparoscopy. Both are equally efficacious to tell us about those implants, and that would help me guide me in the surgery.
So Gore sir, is a PET scan essential for this kind of patient to proceed for further treatment?
Yeah, any ovarian mass can be either primary from ovary or it can be from other organs, as sir said. It can be from stomach, it can be from colon, or it can be many times even from lung. So we have to do the PET CT if you are suspecting carcinoma ovary. First investigation which we have done is CT scan, and I would like to tell CT scan is the best investigation to rule out whether it is a carcinoma ovary. Particularly many times in a fertility group, there is always a question, there is a ovarian mass and how to identify whether that mass is malignant or not. The most important investigation is CT scan with IV contrast. If there is a solid component, there are two differentials. It can be a hemorrhage or clot, or it can be a tumor. If on the IV contrast, if it is an enhancing mass, I think almost diagnosis is certain, it is a neoplasm. And any ovarian neoplasm is 99% a malignancy. So once you have decided it is a malignancy, then we have to differentiate whether it is a primary malignancy of ovary or it is coming from other organs. So I would definitely like to do the PET CT and sometimes even colonoscopy and gastroscopy.
Right, so this is usually the routine workup for any ovarian mass that we encounter in practice. One person had raised a question about screening for CA ovary in the first session. So, Dr. Bhushan, are there any investigations that we can perform? Leave this patient aside, but suppose a patient does come with an ovarian cyst, maybe a 3 or 4 centimeter ovarian cyst, and it has some features which are maybe one septa is there, or the radiologist is not able to exactly tell you whether a solid component is there because it's a small mass. So are there any investigations that we do or some scores that are available for the question that was addressed in the morning, that cancer screening for CA ovary, are there any things which can guide us that yes, this thing could be malignant and we need to process it in that manner?
As per the guidelines, there are no screening modalities available for CA ovary like we have in breast and cervix. Very prominently we have in those two cancers. But if there is a cyst in the ovary and we would like to evaluate whether there is malignancy in it, so there are few scores, like the one is on the screen, the RMI score. The other score is the ROMA score. So these two scores help us to guide whether this ovarian mass or the cyst could be malignant or benign.
So yeah, so these two scores are fairly accurate. The RMI is less accurate compared to the ROMA score. The ROMA score is a very accurate test which has been actually formed as an algorithm. So it's a very complex thing. But you need three values for this. You need the CA125. You need a new tumor marker. So we discussed the tumor markers till now. Now this is a new tumor marker called HE4. So HE4, which is another marker, if it is elevated, CA125 is elevated, and the patient is pre or post-menopausal. Depending on that, the algorithm, so this really complex equation is there, which puts these tumor markers values inside, and they give you a score at the end. And if this score is above this particular value, the patient has a chance of having a malignancy. So these two scores help you really guide the patient whether they are looking at a malignant ovarian neoplasm or not. And this is coming into use more and more now. The ROMA score is fairly recent, and it has been put into practice of late. So, Dr. Vinod sir, what is the next course of management for this case?
Yeah. What is the age of this patient?
55.
Yeah. So this is 55-year female with a ovarian mass, single-sided ovarian mass, and we are suspecting solid mass with enhancement. There is no metastasis. So the next step is doing the laparotomy and excising this mass, because we cannot do the biopsy in ovarian mass or laparoscopic surgery because there are chances of this tumor getting spread to peritoneal cavity. So directly doing the laparotomy and doing the surgery for ovarian cancer is the most appropriate thing. We would like to do the frozen section. We will remove the mass, send it for frozen section. If it is showing malignancy, complete the type 2 radical hysterectomy, bilateral pelvic lymph node dissection, peritoneal biopsy, omentectomy. So we have to do the complete abdominal staging of the cancer if frozen section is showing the malignancy.
Right, so I think you covered all the points that we were going to discuss. I'll just come back to laparoscopy. So Dr. Bhushan, what is your opinion about doing laparoscopic procedures in these patients? Why can't we put in a laparoscope and the cyst is there in front of you, nick the cyst, suction out the fluid, it will collapse. It's obviously, most of it is fluid inside, it's not a very solid cyst. And the cyst will collapse, and you can just excise the ovary or the ovarian cyst and pull it out through one of the port sites. So why can't we do that? You will save the patient. So this 17 centimeter cyst will require 25 centimeter incision to come out. So the patient is also going to have a huge laparotomy, and we don't even know the diagnosis. So what is the reason if you would select laparoscopy and do a cyst excision in that manner, collapse it, remove it through a port, or would you always offer a laparotomy for these kind of cases?
Staging laparotomy is definitely better than a laparoscopy. Doing a laparoscopy and rupturing a cyst would raise the stage from 1A1 to 1A3. So that I would not advise, because that raises a stage due to a surgical spill. Hence, I would advise the staging laparotomy over laparoscopy in such a large cyst. But if the cyst is small, which can be removed intact, definitely a laparoscopy can be used for ovarian surgeries.
Yeah, in this particular patient, actually, if you do the staging laparotomy and do the excision of this mass, you may not require chemotherapy mostly, because this is confined to one ovary and it is early stage. But if you do the laparoscopic surgery, patient is definitely going to require chemotherapy. So by doing or by rupturing the cyst, your patient will require chemotherapy, which may have many side effects.
So I'll take a step back before we go into chemotherapy or the surgical management, and first we come to the diagnosis that benign or malignant. We are still not 100% sure because we don't have a tissue. We are not supposed to biopsy it. But now consider that this patient had a benign tumor, probably your laparoscopic treatment would be safe, because it's a benign tumor, you ruptured it, त्याचा spill झालेला आहे, and still it's benign, so you are getting away with it. But you have no possible way to know if it is benign beforehand. So unless you have the tissue in your hand to say it is benign or malignant, there is no way doing laparoscopy, whatever the vision of the, whatever the appearance of that cyst is, you cannot say if it is malignant or not. And if you rupture a malignant tumor and you cause an intraoperative spill inside, it is directly upstaging the cancer. So you are causing harm to the patient directly. Why? Because the cancer cells may spread inside the peritoneal cavity, chances of recurrence increase, and then chemotherapy is always added to prevent this recurrence. So by just doing a cyst rupture and causing a surgical spill, the patient gets upstaged in a malignant tumor. By chance, if it is benign, you will get away luckily, but you have no possible way of knowing this. Even a cancer surgeon cannot tell you, looking at an ovarian mass, if it is benign, malignant. The radiologist cannot tell you. No one can tell you definitively. So laparoscopy, except for very, very small cysts, is to be avoided only and only if you can remove it intact. The concept is to remove it intact without a spillage or without a rupture. So that is the thing to be remembered when dealing with such kind of an ovarian mass. So Dr. Rahul, what is the plan for adjuvant treatment in a patient who has a solitary ovarian mass confined to one ovary? What are the factors you need to see in the final report? So he has done the surgical staging, he has done a hysterectomy, oophorectomy, he has removed the momentum, peritoneal biopsies are done. Now, what are the factors which will guide your plan for adjuvant treatment in this kind of patient?
So basically we will have to see the entire histopath report, though it appears that the mass is confined to the ovary, but whenever we see the histopath, we also look at the omentum, the peritoneum, the nodes which are removed, and based on that, whatever structures are positive, if any other structure apart from the ovary, like omental deposits or nodes are positive, all these patients, they definitely need adjuvant chemotherapy. But if all the rest of the staging report is negative, and if the tumor is only confined to the ovary, and if it is not rupturing the capsule, if it is only stage 1A, then maybe in some cases we may avoid chemotherapy. But again, we also see the histopathological type of the tumor, ovarian type of the tumor. If it is clear cell carcinoma, if it is a high grade carcinoma of the ovary, still these patients who are confined to the ovary, they warrant adjuvant chemotherapy.
So, if this patient had to go ahead for chemotherapy, what are the side effects that you would counsel them? We are always like now it is an early ovarian cancer, but still due to certain factors, as you mentioned, the patient has to go for chemotherapy. So, what are the side effects that most people are going to be concerned about, and how would you tell them about it?
So generally these side effects are whatever all of you have already heard. Like chemotherapy, it is non-selective treatment, so it will act on all the rapidly growing cells. So apart from the tumor cells, it will also kill the cells of the human body which are rapidly growing. That includes hair, the nails. So there will be hair loss, there will be blackening of the nails. There can be side effects like leukocytis or WBC, lowering of the WBC counts or increased chances of infections. But to be honest, the chemotherapies which are given in ovarian cancer, it's a standard protocol. All the patients, they receive paclitaxel and carboplatin. Nothing else is given generally in 95 to 99% of the patients. And both these drugs are now very well managed as such. There are very good effective treatments to avoid the side effects as well as mitigate the side effects. And most of the times the patients, they generally don't have significant side effects. Only 5% patients can have, but that can be very well managed.
I think the most concerning side effect from what you mentioned is hair loss. No woman wants to lose her hair, and many people we have seen actually turn away from the treatment just for that one reason ki hair loss no hai. So is there anything that you can do today to prevent this hair loss?
So today we have some of the options. One of the options is a scalp cooling machine. Now the reason the hair loss happens is because the drug penetrates the scalp, and because of that the hair follicles are damaged and the hair loss happens. So now what we can do is we can put a scalp cooling cap or machine that reduces the temperature of the scalp during the time the chemotherapy is administered. So what happens is, because of the scalp cooling, the vessels in the scalp are constricted, and the chemotherapy drug delivered to the scalp or the hair follicles is reduced to a significant extent, and that can help to reduce the hair fall. One point to importantly note is that it will not completely prevent. If you are having the belief that it will completely avoid, no, it is not. The drugs which are used in this chemotherapy, paclitaxel, it is a strong chemotherapy. The extent of hair fall can be reduced. That is what we can achieve, and that may have some cosmetic benefits to some of the females, and if that can help them, we can definitely try to reduce the hair loss.
Right, so this is available with us. The scalp cooling machine is there. It can be used for 2 patients at a time. It cannot be used for too many together. And it causes cooling of the scalp to a level where you can reduce hair fall by almost 40 to 50%. As sir said, it is not completely preventable. It's not that hair fall won't happen, but yes, a significant amount of it can be reduced. So this is just a short synopsis of the early ovarian masses that we see. So looking at this giant tumor, you feel it's a very advanced cancer, but actually for us, it's a very early cancer because it is confined to one ovary. Ovarian cancer staging depends on how much the tumor has spread in the abdomen. And confined to one ovary, even if it is a 20-25 centimeter mass, but still confined, it is still a cancer stage 1. That's very important to remember, and that's why it should not be upstaged. We'll go on to the next case. 65-year-old lady. She has diabetes, she has hypertension, but well controlled. Also having some family history of a mother having breast cancer who's treated and doing well. Now this lady, she started having pain in the abdomen and gradual distension over a few months. She's had constipation since 1 month. She's had loss of appetite. She's saying that she's had weight loss, but we don't know how much. In our books we read significant weight loss means so many kgs in so many months, but most patients will not give you this history. They don't know how much weight they have lost, but yes, they will say that the clothes are loose or they are not fitting well. And always having nausea after eating any amount of food. So the first obviously this person will present to a surgeon or a physician, and they will do basic investigations. They are not going to think of ovarian cancer in their first thing. These are very vague symptoms which could be due to any possible reason. So they do an X-ray and they do a sonography. Dr. Gayatri, would you like to comment on the X-ray and the sonography findings?
So this is an X-ray which we would call as a gasless abdomen. There are absolutely no gas shadows seen on the erect X-ray of the abdomen. We would definitely like to proceed with the next CT scan of the abdomen and pelvis with contrast to look for intestinal obstruction.
Right, so as you can see in this X-ray, there is no bowel shadow seen. Normally air fluid levels or something would be seen, or you would expect that in a patient who has some obstructive symptoms, the bowel will be distended. But in this kind of patient, it is completely free of any air. So most likely in such situations, you would get a sonography with these kind of findings, that the patient is having a distended abdomen, gross ascites, the bowel is having a to and fro peristalsis, which is not good, as in it's showing some amount of obstruction, and omental deposits may be there in the sonography findings. So as ma'am said, the next investigation is going to be a CT scan. So would you like to comment on the findings of the CT scan, and especially at what the arrows are pointing towards?
So on the CT we see that there is gross ascites, there is a lot of omental thickening, nodularity, there are enhancing omental nodules resulting in omental cakey, and there are omental nodules in the upper half of the abdomen as well. So we would definitely think of a malignant peritoneal disease.
Right, so this is what omental deposits look like. So when we think of the omentum, we think of as a layer of fat. But where does it actually see? Where do you see it on the CT scan? It's at this point, just under the anterior abdominal wall. And if there are deposits there, they can definitely tell you that this is omental deposits, and omental involvement is there. The same thing can be seen on different quadrants, and it can be shown as peritoneal disease. So if the peritoneum is involved and multiple deposits are there in the peritoneum, you can pick it up actually on the CT scan as well. And you can see the gross free fluid, which indicates that there is gross ascites. Dogore sir, what would be the next step that you would take for this patient?
Yeah, this patient is already having extensive peritoneal disease. So first thing is you should do the PET CT, complete radiological staging of this patient, and then we have to achieve the tissue diagnosis, because mostly this patient is going to require neoadjuvant chemotherapy. So I would like to do the PET CT to rule out whether it is coming from stomach or any other organ, and then biopsy, either USG guided biopsy from the omental nodule, or if biopsy, USG guided biopsy is not possible, then laparoscopic biopsy can be done in this patient.
So in this much fluid, can we do an ascitic tapping? Is
Ascitic
that possible?
tapping also can be attempted first. If we get diagnosis of adenocarcinoma on ascitic tapping, then there is no need of doing biopsy.
So Dr. Mihir, what would your opinion be regarding doing an ascitic tapping, and what are the tests that you would expect to be advised in such a patient? Now we don't have a diagnosis, we have elevated tumor markers, there is gross peritoneal disease, and there is free fluid. So they are going to do ascitic tapping. What are the recommendations for testing that you would give to the clinician who is sending it to you?
Yeah. So first of all, what we might get initially is ascitic fluid cytology. So we have to do a thorough assessment of the cytology smears, and we should be sure, it should be an if you are suspecting a malignancy, you should be 100% sure that whatever tumor clusters you are seeing under the cytology slide are malignant. Because many times what happens in cytology, reactive mesothelial cell clusters can mimic tumor cell clusters. You have to be 100% sure before committing to a diagnosis of that it is an involvement by say malignancy or adenocarcinoma, that they are not reactive mesothelial cell clusters. So if there is a doubt in your mind that no, these could be reactive mesothelial cell clusters and not adenocarcinoma cells, you should do a cell block. So the ascitic fluid can be processed similar to what histopathological processing is done, and we can get slides similar to biopsy blocks. So what is the advantage of doing that? First of all, we get a little better architecture that way of those clusters. Nuclear atypia can be a little better assessed, and most importantly, we can do ancillary tests such as IHC on those cell blocks, okay, which can enable us to differentiate between reactive mesothelial cells or whether it's a adenocarcinoma from ovaries. So cytology and if required cell block is what we will advise in such scenario.
Right. My next question to you is something that we see frequently being missed is what is the quantity of fluid that you need to come to the lab for doing an adequate sampling?
Yeah, so there is actually no fixed quantity. Means actually from our side, we advise to send whatever amount we receive during ascitic tapping. If almost entire of that sample is sent, maybe it could be 1 liters, 2 liters, then it will definitely help us, because if it is strongly suspected in the cytology that it is an involvement by adenocarcinoma, then we might process it again, we might do cell block again. So as much as possible, sample should be sent to
So I think it's important to know this, because many a times what we do is, when we are doing an ascitic tap, we just remove 20 cc for the diagnostic purpose. We send it for protein, sugars and ADA levels, and cytology is also sent in that 20 ml only. But that gives a very, very small quantity to the pathologist to actually examine for malignant cells. Malignant cells are examined after centrifuging. So they get the residue in the bottom, and then they take that and make a slide or a cell block from that residue, whatever the cells are collected in the bottom of the centrifuge. So if you can send the entire sample, that is the best actually. So actually we sent like an entire can, the jerry can se purna can che can 1 to 2 liters we send to them for examination, and they will process it. They will process the whole sample, and that is ideal. Do not send only 10 cc or 20 cc unless that is the only sample which you can get. If you are doing a drainage or you are doing a symptomatic relief for the patient, symptomatic relief, you are draining 1 liter or 2 liters of fluid, take the whole sample and send it to them in a clean container. It need not be sterile also. It's not required that the whole thing has to be sterile. It's only a clean container. So in an IV bottle, in a can, in whatever samples, collecting specimen jar you have, you can send the whole thing to the lab and they will process it. So that is rather important to remember when we are doing a processing. Dr. Bhushan, if this cytology came negative?
If it comes negative, still we have to have some histology report before proceeding. So we will go for a diagnostic laparoscopy, or we can also use the UAG to get a targeted biopsy from the omental nodule or the ovary.
Right. So obviously, if it is possible to biopsy some particular nodule, definitely our intervention radiologists can do that. They can put in a needle and get the biopsy. If that is also not possible, only nodularity or thickening of the peritoneum is seen, but many times we need to go ahead for a diagnostic laparoscopy to confirm our findings. Most of the times you will see something like this. Gore sir, what do you think when you look at this in a scope? Like you put in a scope, you are looking at this kind of disease inside. So what is your impression?
Yeah, it is multiple peritoneal deposits. There is a seedling on the peritoneum, and we can biopsy those white nodules and send it for closer section.
Right. My next question actually is little reverse. Can this be TB?
Yes, it can.
Yeah. So it's important to remember that
while sending ascitic fluid, usually when patient presents like this, we also send the ascitic fluid for workup for tuberculosis, like gene expert and microbacterial culture.
So it's important that even though we come from a background of cancer, it's not always going to be cancer. Tuberculosis is extremely prevalent in our country. We have had many cases who are presented in this exact same manner. We always think that hey, cancer hai, cancer hai, cancer hai, and then we get the biopsy and it is TB. It comes quite often. It comes more often than you think. So it is very important to also keep this in mind that this could be tuberculosis, and if it happens, then I would say the patient is lucky because it's not cancer. So ascitic fluid adenocarcinoma cells seen. I'll come to Dr. Bhushan. So now I'll come to Dr. Mihir and Bhushan in a while. So you spoke about ascitic fluid cell block. Could you just give a small description as to what it is?
Yeah. So normally what happens during the processing of biopsies which we get, we finally get what is known as a paraffin block, which we can convert to as many slides as we want. So usually that advantage is lost in cytology where we only get smears. So what is the advantage of this cell block is that we can do ancillary studies such as immunohistochemistry on those cell blocks. So they are paraffin blocks and we can subject them to immunohistochemistry studies or sometimes even molecular studies. So that is the advantage of cell blocks. We can process the fluid like we process it for histopath and then we get the blocks. So on that we can do immunohistochemistry to confirm that it is an ovarian tumor, what type of ovarian tumor, and also whether it is a high grade or low grade tumor. So that is a huge advantage of cell block and immunohistochemistry. So usually in such a setting, we do if on imaging an ovarian mass is very strongly suspected, we usually use a panel of 4 immunohistochemistry stains: PAXET, WT1, P53, and ER. So PAXET marker is, gives us an idea that it is an ovarian tumor. It is a genitourinary marker. So PAXET. Then WT1, in the cell block, this particular advantage is lost because WT1 can also be expressed by the mesothelial cells. But in the biopsy setting, WT1 is a good marker. It can give us an idea that it is a serous adenocarcinoma. Then about the grade of the tumor also we can comment on based on P53 features of P53 immunohistochemistry. Usually the grading is based on the nuclear variation, but sometimes because of issues in the fixation and all, on the histological slide we may not always get that kind of variation. The cells might look very similar, but it can still be a high grade carcinoma. So if there is a diffuse P53 nuclear expression or the complete loss of expression, we should call it as a null type phenotype, we can say with confidence that it is a high grade serous adenocarcinoma. That is the advantage of cell block as compared to cytology.
Right, so it helps us to also give subtypes. We give the name, it's not just ovarian cancer, it's what kind of ovarian cancer, and this has a implication in the treatment methodology and the prognosis also of the patient. Each of these subtypes behaves in a different manner. They don't behave the same way, although treatment may overlap, but the prognosis of each of them is very different. So we've been talking about adenocarcinoma till now. There's another kind of ovarian cancer that we deal with. So Dr. Mihir, could you give us an idea about what sex-cord stromal tumors are?
Yeah, so the sex-cord stromal tumors, these are a type of ovarian tumors which can either be purely stromal or purely sex-cord or can be a mixture of both. So the most commonly encountered sex-cord stromal tumors, the purely stromal tumors are fibromas and thicomas, or the malignant counterparts like fibrosarcomas. And the sex-cord tumors are most commonly thicomas, then steroid cell tumors. So all these are sex-cord stromal tumors. Then another type of tumor, sex-cord tumor with annular tubules. So these are all kind of sex-cord stromal tumors.
Right. So this is also another kind of ovarian cancer which has a different cell of origin. So if there's adenocarcinoma, it comes from the epithelial cells, which are epithelial ovarian cancers. And this is another group of cells inside the ovary which can also cause cancers. And they are also present in this way only, the same way. There's no difference in the two things. So this is also another cytology, something which we get on the cell block. We can actually find out what kind of cancer it is. So I come to Dr. Bhushan now. What would be the plan of management from your point of view?
There is a lot of ascites, there is a lot of vomital nodules, the disease seems extensive. So I would hand over the patient to my medical oncologist colleague for neoadjuvant chemotherapy.
So Dr. Rahul, patient has come to you. What can you tell us about the chemotherapy used in these cases and what are the expectations that we have from this kind of chemotherapy?
So the chemotherapy, as I said, the plan of chemotherapy is generally the same irrespective of whether we use it in the neoadjuvant setting or in the adjuvant setting. So as I mentioned, there are only two drugs generally which are used. One is the paclitaxel or the taxane, and another is the platinum. That is the most important drug which is used in the chemotherapy. And whenever the oncosurgery colleague feels that the disease is quite extensive and he cannot remove the entire disease, the principle of ovarian surgery is that the tumor has to be removed in toto. Whatever of the grossly visible disease is there, it has to be removed. And if that is not going to be possible based on the radiological investigations, then chemotherapy definitely helps. If we give chemotherapy before the surgery, maybe 3 to 4 cycles, it gives a significant response in most of the patients. Almost 80 to 90% of the patients, they have dramatic response. We can judge the response based on the CA125. So this patient had a CA125 more than 1000. After maybe 2 cycles, we can repeat the CA125, and based on the degree of the reduction in the CA125, we can assess or we can judge how the patient is responding. After 3 to 4 cycles, we repeat the scans and we can really see how much the patient has responded on the radiological investigations, and based on the response, the surgery can be planned like the opposite.
Right. So now another question, that this patient, as we saw, was quite sick to start with. She had a lot of symptoms, gross ascites, unable to eat food. So now when you plan chemotherapy for such a patient, we've done the diagnosis and we've handed over. Dr. Bhushan has given you the patient now. So what are your considerations for her chemotherapy now? Are you going to start her with the routine doses of chemotherapy? Is there any modification would you like to do? And if so, then what modification and how does it help the patient?
So basically, one thing we have to understand is that the patient is sick because of the disease. So unless and until we tackle the disease, the patient's general condition is not going to improve. And basically, because the disease is in the abdomen, the patients get a lot of symptoms. So this is what the judgment, clinical judgment is. If we feel that a patient is fit enough and there are no other comorbidities, we can still go with the conventional chemotherapy which is given every 3 weekly. But if we feel that a patient is weak, patient is not nutritionally well managed, then we can even split the chemotherapy into weekly regimen. So weekly regimen, it is easy, it is convenient, the doses are low, so the tolerance is better in those kind of patients, and even the response is equivalent to the 3 weekly regimen. And after giving initial chemotherapies, once the tumor burden goes down, the patient starts getting symptomatically better, their appetite improves, and obviously the nutritional status also improves. And once the disease and the nutritional status is very well managed, then even the surgical outcomes and the quality of surgery which can be performed after the chemotherapy definitely improves.
Right, so it's important to understand that every patient is not the same. Every patient who comes to the clinic is not going to be in the same fitness condition, in the same physical health. So they can definitely modify the chemotherapy cycles, the dosage, everything can be changed according to that patient to give them the best outcome. You give them the symptom relief, they will do better. After 1 month, that patient will be walking, they will be eating food. The nutrition is improved. So you are improving gradually. Step by step, you are giving small improvements and taking them towards an outcome which eventually involves surgery. So now that Dr. Rahul has finished his chemotherapy, the scans are showing a good response. Dr. Bhushan, what kind of surgery would you offer? This concept of cytoreductive surgery has come up now in this interval setting. Could you give us a little bit of idea as to what it involves?
So whatever gross disease is visible or not visible on the peritoneum, each and every peritoneum has to be addressed and removed. So doing a total abdominal hysterectomy with bilateral salpingopectomy is not enough. Taking peritoneal biopsies if nothing is seen, but if anything is seen, removing the entire peritoneum.
We are talking about this case. So for example, this kind of situation that you saw the images of. Now this patient comes up for surgery.
So doing a THBSO with omentectomy with bilateral nodal dissections along with peritoneectomy from each and every quadrant of the abdomen. And if other organs are involved like spleen, colon or small intestines are involved, excising each and every organ where the peritoneal disease is there is the complete cytoreductive surgery.
Right, so the concept has moved now. Earlier there was something called as debulking surgery for cancer of the ovary. Debulking is what used to be there in the textbook. Over the last decade we have moved on from there. Debulking used to be key, you could remove the gross disease, so whatever is excesses you could remove and leave behind less than 1 centimeter tumor. Even if it is 100 nodules but 1 centimeter se kami aaye, you can leave it behind. That concept has completely changed now. Today you want to remove each and every nodule that you see inside. So when you open the abdomen, whatever is there inside, if it is possible to remove, it should come out. So that means doing extensive surgery, which has, the grade of surgery has increased dramatically. We can do this now safely because we have good experience for it. The patient outcomes are definitely, yes, the morbidity is going to be there, but the outcomes are good. The patients take some time to recover from these kind of extensive surgeries, but they do well. And we are giving them the best disease clearance, which is important for their future prevention from recurrence or prevention of a relapse. So these kind of surgeries, though they are very extensive, you remove organs, you remove colon, you remove the rectum sometimes, but you achieve a complete disease clearance, something that we call a R0 resection. If you can achieve that, it has been proven by trials that R0 resections are the best and they have the longest surviving patients if you give them a complete disease clearance. So no more the concept of debulking is there. You need to go ahead and do a cytoreductive surgery. Most people need to be specialized to do this kind of surgery. It's not done by every single, even oncosurgeons need to specialize to do this kind of surgery because it requires a lot of skill, effort, time. And the patient outcomes also have to be managed with a very skillful team. So this is needed for getting the best outcomes in ovarian cancer. After cytoreductive surgery, the next concept which has come, Dr. Gore sir, would you like to give us an idea of what HIPEC means?
Yeah, HIPEC is intraperitoneal chemotherapy. When we do the cytoreductive surgery, in the cytoreductive surgery, we remove everything, all peritoneum from the abdominal wall as well as bowel. We remove all peritoneum, but bilateral salpingoverectomy, hysterectomy, lymph node dissection. We have to remove the peritoneum from the diaphragm. So this surgery takes around 12 hours, 14 hours. So after this extensive surgery, you have removed peritoneum from all the organs, and then we instill the chemotherapy in the peritoneal cavity. whatever the residual cells are there, those cells are killed. So this procedure definitely shows better result. You can see these are the tubes that chemotherapy drug is going into the peritoneal cavity, and from one tube it is coming to the machine. So there is a special machine for HIPEC. This is hyperthermic, so that temperature also has to be maintained. So this machine maintains temperature. So this is actually very extensive surgery and extensive procedure. It requires lot of skill, good team, and even good post-operative care.
What is the temperature, sir?
Temperature.
So it's usually maintained between 40 to 42 degrees. So in this period, what happens? This is the end of the surgery. So you've done almost a 10-12 hour surgery for the patient. The anesthetist has been extremely important in that entire thing. And now what happens is you want to raise the body temperature to a very high level. So they have to start cooling the patient beforehand. Normally in the OT we are warming the patient with warmers and everything. Here it's other way around. You have to start cooling the patient. Once you cool the patient and they give enough fluids, because this chemotherapy is also going to affect the kidney. It gets absorbed to the peritoneum. So you have to make sure the patient is well hydrated, the patient is the temperature is brought down to a certain level, which this heating is not going to affect it that much, because obviously heat is going to cause coagulation and damage. So 40 to 42 is the safe limit. That is the temperature it is maintained throughout a period of around 60 minutes. The chemotherapy drug is introduced and circulated in that basin, like we create the basin inside the abdomen, and that is done for around 1 hour, 60 minutes. So this is the routinely followed procedure for HIPEC. And after this, then we finish the closure and the patient is shifted to the ICU. So most of the patients are going to stay in the ICU for 1 or 2 days at least. So this is a short picture of what HIPEC looks like, and this is what we do for ovarian cancer. Today we have data that has compared not doing HIPEC versus doing HIPEC, and the survival in HIPEC has shown to be superior, it's better. So definitely we can give this to our patients after that entire surgery is done. This requires specialization, this requires a good team. Intraoperatively, anesthesia and OT team has to be excellent, and post-operatively your ICU and the ward care has to be excellent. So only then we can get these patients to a really good outcome. So I think that about covers the surgical part. I'll just take a short note from Dr. Rahul as to now we have done this kind of procedure. Now what is the adjuvant treatment for this patient, or what follows up after this kind of treatment?
So generally as a norm, the number of chemotherapy cycles which are required in any chemotherapy, in any type of cancer are generally roughly around 6. So same holds true for ovarian cancer. So we give 6 cycles of chemotherapy. If the neoadjuvant chemotherapy is given for 3 to 4 cycles, the remaining 2 to 3 cycles are completed post-surgery. So that is the basic minimum treatment which is required. So even after you do adequate surgery, there can be chances that there can be slight micrometastases which are left, and to cover up that, we give adjuvant chemotherapy. After that, what new things have come up is the targeted therapies and maybe the anti-angiogenesis inhibitors. So initially, only chemotherapy was having a role in ovarian cancers, but then later on, we now have drugs called bevacizumab, that is anti-angiogenesis. Now what they do is they reduce the tumor blood supply, and we know that the tumor cells grow because they acquire the new blood vessels, and that is where they feed on. So if we reduce the blood supply to these cells, ultimately these tumor cells are going to die, and maybe the chance of recurrence are going to go down. So that anti-angiogenesis inhibitors can be given for 1 year. If the patients are having a genetic history or hereditary history, they can be tested for BRCA. Almost all the cancers for ovarian cancers have to be tested for BRCA, and if they are positive, we now have some tablets in the form of PARP inhibitors, and we can give them for almost 1 to 2 years, and that has also shown that it reduces the risk of recurrences in the first 5 years. So these are some of the treatments which are given in the adjuvant setting.
Right, so there are a lot of therapies still remaining. It's not that this is the end of the treatment. The chemotherapy has to be completed. Many patients will require some amount of targeted therapy if they are suitable for it. As sir mentioned, we look at the mutations. We've been listening to mutations since morning. Here also, same thing, mutations. If those mutations are there, they are eligible for receiving the targeted therapy. Dr. Rahul, is there any role of radiation? We've listened for radiation for all the cancers till now. Suddenly, where has radiation gone?
So as a guideline-based approach, there is no role of radiation in ovarian cancer. only and only if the patient is metastatic and if there are a tumor which is causing more symptoms, especially in the bones. In selective cases, we may consider radiation for palliation of the symptoms, but otherwise, this is one malignancy where radiation in a definitive treatment has no role.
Right. So this is a situation where till now we have heard chemo, radiation, surgery. Here, radiation really does not have a role unless it is for specific bony pain or patient has got metastasis to that side. Dr. Bhushan, how would you follow up this patient after you have finished your complete treatment, adjuvant treatment is over? What is your schedule for following up? Could you let us know, let the audience know a bit of importance about following up a patient?
So follow-up is required because maximum cancer recurrences occur in the first 5 years, be it ovarian cancer or any other cancer. So usual guidelines say that the first year or the first 2 years we have to follow the patient every 3 monthly. Later on in the third year we have to follow up every yearly, and then or some oncologists require a 6 monthly follow-up up to 5 years and later on yearly. Or some oncologists want a 10-year follow-up after which they do not wish the patient to follow. So some investigations which are required during each follow-up are if a CT scan has been done previously, so a CT has to be repeated. If a PET has been done previously, then a PET has to be repeated. So it depends on the investigation which was done pre-op or starting the treatment. So that radiological investigation has to be done for every follow-up so that we get an exact measurement of recurrence or if relapse has occurred. Other than that, tumor markers have to be done on every follow-up. In this case, a CA-125 has to be done on every follow-up 3 monthly in the first 2 years and every 6 monthly for the next 3 years.
Boris, sir, any comments regarding what do you advise your patients?
Yeah, regarding first of all tumor markers, many times the CA-125 is actually mainly marker for prognosis or marker for follow-up, because even though tumor CA-125 is raised, many times people ask us if CA-125 is 100 or 50, so what to do? They consider it as a cancer. CA-125, increase in a CA-125 doesn't indicate that patient is having cancer. It only indicates that there is some pathology in the whole. So don't consider as a diagnostic marker. CA-125 is not a diagnostic marker. Many times we do the alpha-fetoprotein, and if it is more than 1000, we consider it as a hepatocellular carcinoma. Or in PSA, if PSA is more than 100, it is a diagnostic marker. We consider as CA prostate. But CA-125, many conditions like simple ovarian cyst, tuberculosis, it is raised. So our purpose of doing CA-125 in pre-op workup is mainly to monitor this patient post-operatively. So post-operatively, if suppose pre-operative CA-125 is 400 and now post-operatively you are monitoring, so CA-125 is remaining in the range of 15, 10 and suddenly it has increased to 500. That indicates recurrence. So please remember that we have to do the CA-125 during follow-up, and definitely other investigations like PET CT maybe once in a year or once in 6 months depending on the disease status. And again one thing, many times even we see lot of patient, male patient with CA-125 done. So CA-125 is very routinely done as a screening test, so it is not a screening test. And as we are speaking about tumor markers, if patient is young, 22 years old girl is having ovarian tumor, along with CA-125, you have to do alpha-fetoprotein, beta-HCG and serum LDH, because usually these are germ cell tumors in young patients.
Right, thank you, sir. So I think that's an important point, that follow-up has to be maintained for these patients. It's not that the treatment is over, go home and come back when you have a problem. It's not like that. We always follow up this patient very routinely. You usually recommend 3 monthly because for 2 years the highest chances of recurrence are there, and we have to monitor them very carefully for side effects also. Side effects of chemotherapy, side effects of surgery. This also comes up in the first 2 to 3 years. So I think that brings us to the end of this session, and I would like to thank my panelists. Thank you for a very great audience. If you have any questions, please go ahead. Yes.
Sir, for the recurrent ovarian CA, different oncologists follow different protocols. What are your view about that? And this is the first question. And the second question is, just mere pain relief is not palliative care. So what are your views on the palliative care?
So Dr. Rahul for the first question, Dr. Bhushan for the second question.
So you are asking about a recurrent ovarian cancer. So while dealing with recurrent ovarian cancers, we first see when the recurrence has occurred. If the recurrence has occurred after maybe 6 months or 1 year of the initial treatment, then these patients are generally sensitive to the initial chemotherapy which are given and which has responded. So the protocol is the same, generally the same what the patient has initially received, and maybe selectively depending upon the extent of the recurrence. If the patient has behaved well after the initial surgery and chemotherapy, we can also think of offering them a secondary cytoreduction in some cases. But on the contrary, if the patient has recurred immediately after completion of the treatment, say for example the patient has completed the 3 cycles of adjuvant and immediately in the next 1 or 2 follow-ups in the first 6 months the patient has got a new peritoneal disease, the CA125 started rising, the new ascites have started forming, then these patients are generally resistant. So based on the amount of duration which has lapsed after the initial treatment, the treatment protocols are decided. So that is one thing where how we decide the treatment, and plus based on the molecular profile, as I said, if the patient is BRCA mutated, we also come to know that these patients are going to be sensitive to some sort of chemotherapies or some sort of targeted therapies, and we can offer them that kind of treatment. So the treatment decision is based upon the nature of presentation and the time of presentation. And when it comes to palliation, your next question I would like to ask Dr. Bhushan to comment upon.
Is that answers your question? The question about recurrent ovarian cancers?
Is olaparib and all, is it available nowadays?
Yes, it is of course.
And what is the cost around it?
So olaparib initially it was only available in the original form which was available from the multinational companies, and the cost was somewhere around 1.25 lakhs per month. Now the Indian generic companies have also come, so the cost has reduced, but still it is in the tune of around 70 to 80,000 per month. But olaparib is not the only PARP inhibitor which is available. Now we have other PARP inhibitors like rucaparib, and the cost of that is somewhere up to 50,000 rupees per month. So based on what is indicated for that patient, based on the indication, either of these PARP inhibitors can be used.
So Dr. Bhushan, regarding pain is not the only palliation. What do you have to say about palliative care?
So there are two things, one is hospice care and one is palliative care. So hospice care means we do not take any active interventions for anything, we just give symptomatic care at home or any hospice. Palliative care means we take care of the pain, and it could be also other symptoms like spiritual, the patient has to be maintained mentally also and socially also. So all these care include the palliative care. So other than pain, the mental, spiritual and the social care has to be taken. That includes palliative care.
So I think what we want to say when we say palliative care is a complete holistic management of the patient. Many people think that palliative care is end of life care. That's not true. Palliative care is palliation of any problem, symptom, mental, physical that the patient may be having. When you deal with palliative care, it actually starts from when the patient walks into your OPD. It starts from there. It's supposed to be incorporated into your therapeutic treatment as well. That you are treating therapy, you are treating the cancer and giving palliation at the same time. So whatever methods are needed for palliating the symptoms of the patient and providing the best quality of life is palliative care. Unfortunately, in our country, it equated to end of life care. That nothing else is there, chalo palliative care ko jao. That's not true actually. We need to start incorporating it much earlier in the treatment plan. And that will help the patient get the best outcome at the end. Even though, yes, obviously, end of life also is included in palliative care, but that's not the only thing that we look for. I think we'll just go on to the last session. I request you all to just be there for this. It's a very important session. Actually, the most important, I would say, from our point of view, that handling distress or emotional distress in cancer patients, you will all face either a patient, many people unfortunately have a family member who has been diagnosed with cancer and they need treatment for it, and handling distress in them is definitely an important aspect which even doctors don't know how to do. So I'd invite Ms. Rebecca D'Souza, our in-house counselor and psychologist, to give a small discussion and talk about this. Thank you to the panelists.
What do you think are the main psychosocial problems cancer patients face? Let it be interactive. Yes.
Acceptance.
Okay, they face they're unable to accept. What else?
Fear of dying.
Fear of dying? Only dying? All of us are fear. I'm scared of dying.
Fear of the loved ones.
A fear for their loved ones. That okay, because of them, they feel.
The whole routine of the family will get upset.
Okay. There's a disturbance in the. What else?
Surgery, chemotherapy.
Financial burden is excessive. What else?
Uncertainty.
Uncertainty, fear of uncertainty. What else? Body image, there's a change in the way I look at myself. So what would happen if I feel that I'm not looking good? What would happen to me? I withdraw. So social isolation is a problem. What else? Come on. Imagine your patient is sitting in front of you. What are the problems you think they're going to face? Depression. What else? So let's a little few facts. 70% of patients who have been diagnosed with cancer at one point of their life will face depression. We are a depressive country. We have the highest number of depressions in the world, along with diabetes. So depression is a big part. But there's another problem that we face.
The patients are not able to understand what is happening.
There's a fear of lack of control. I don't know whether you realize, I'm the only non-medical person sitting over there. But when I listen to all the doctors telling me, I don't have control. I don't know how to make a decision. I don't know what to choose. And sometimes everybody else is choosing and I'm not choosing. So if you look at broader psychosocial disorders, the highest or the topmost one is mood disorder. Which would so in mood disorders would we have sadness right up to acute depression. So you will have a patient who does not follow doctors. I mean, what are the general symptoms? How would you recognize? A is a refusal to do anything that he loved to. If a patient was drawing, for example, it just doesn't interest that person anymore. If the person was interested in dressing up, painting their nails, if it's a female patient, or if it's a male patient, then the way he dresses up, all of a sudden he's not interested. It's a symptom, it's a sign that there is a problem. Withdrawal from family, withdrawing, so you'll find a lot of times patients don't talk to each other. They don't talk to their family members. They just remain in their room. So depression, these are the signs of depression. Then the second mood disorder is irritability and anger. You'll notice this how? A lack, arguing with the doctor. This is not what I want, or asking repeated questions. Can I do this? Can I do that? Or the spouse or the caregiver telling them that, listen, small things make him very angry or make her very angry. She snaps. Recently, we had a husband who came and told the mental health team that my wife just doesn't leave her child alone. Her daughter was in the 7th standard, wanted her by her side all the time. If she didn't come immediately, she would snap at her. So irritability and anger is quite a lot that we see in patients. We see a lot of fears, that's the mood disorders, and we have the anxieties. So anxieties would be fear of death, fear of uncertainty, fear of for my family, fear of causing a financial burden on my family, fear of dying. Death does not scare us because we all know that it is going to come at some point of the other. But I can't control the way I die. So they are scared of the pain they may experience. They are scared about, so every time they do a test, they're scared about the results. So it's a fear of the process of dying. Okay? So in those terms, one of the contributing factors to fear is therapies, whether it's surgery. So we've had a young girl, 25 years old, who refused surgery because she was scared about the disfigurement. So she opted only for chemotherapy. It didn't matter whether she lost her hair, but she didn't want to lose her breast. Finally, it took us, I think, about 3 or 4 years to finally get her to concede to a surgery. So we have patients who don't want to come for chemotherapy. They actually bargain with the doctors that, do anything, but I'm not coming for chemotherapy. And it doesn't matter at what age these patients are. Okay? And a very small percentage of patients face post-traumatic stress disorders or problems. So even after completion of treatment, a year or 2 years, they do complain all of a sudden of depression, which one of the major symptoms is acute fatigue, unrelated to the disease or the treatment, but they're just tired all the time. Insomnia is another symptom of PSTD. What else? Everything else. Not wanting to do anything, disinterest, lack of focus on themselves, not wanting to communicate with family members. How do you treat this? As physicians or as doctors, recognize a problem. A lot of us do not ask a patient first is, have they had a history of mental illness? Because if they have had existing depression or undiagnosed depression, it is going to affect the quality of life. All this is for what? All this chemotherapy and radiation and surgery. What is the end purpose? That they should have a good quality of life. And if we don't address mental health, then we're just treating the cancer, but we're not treating the person. So A is ask whether they've had any pre-existing mental health issues. B, offer support, not in the form of pamphlets, but I'm there if you need any more information. So one way I feel most patients actually take control is when we sit down with them and we explain in their language what the doctor is trying to communicate. So if we are saying surgery is important, we are telling them that this is one way of reducing your risk of dying or death. Or it is extending your life so that you can fulfill your responsibilities. So you use their language to communicate what the oncologists are trying to say. And honestly, so I'm there at the department. Dr. Rahul has a whole list of patients seeing him. The radiation oncologist has. The surgeon has. They don't have the time to address these problems. So this is what I feel, and this is my suggestion, is that when they come for follow-ups, whether it's a cold or it's fever or if it's flu, you need to address mental health at that level also, because it may not be addressed at the treatment level. So recognition, if there is a problem, referral, if you feel that you are not able to solve the problem. So if you have a patient who keeps asking you the same question again and again, it means there is something lurking behind this behavior. It may not be your capacity to deal with it because you're not trained to deal with it. I'm not doubting your experience or your skill, but your training is not in mental health. So referring them to the right person. If you feel it's a mild anxiety, you can refer to a counselor. If you feel that this particular person needs some kind of psychotherapy, then you refer to a psychologist or to a therapist. If you feel that medication is important, you do refer to a psychiatrist. Often we do refer our patients to psychiatrists and we combine them with therapy. The medicine is going to help them accept certain changes within their lifestyle so that they're able to cope with the mental health problems. The other way we can help is what we call a peer support. So mostly we try at our end to match a newly diagnosed patient with an older patient or an older survivor. Because even though I'm a counselor or a mental health, I have not walked in her shoes, or his shoes. So when you match them, they're able to deal with it better. So we have a one-on-one individual matching, or we do what we call a group counseling where we have a support group. So we just had one on 8th of March, and we had a whole bunch of women who had never been a part of a support group or never interacted with other patients. And they ask questions which doctors don't ask. There was a young lady who asked questions regarding sex, which they feel a little shy. There's a lot of hesitancy to talk to the doctors, but they were able to open up with that, with how to deal with intimacy. How do I deal with, I want children, but the doctor is asking me to remove my ovaries. How do I deal with that? So group support really helps. What you can encourage, how many of you all exercise every day? Well, if you all don't exercise every day, you cannot recommend it to your patients. They're not going, we live by example. Somebody's put both his hands up. So I suppose that's for him and for his spouse. What you can do, what do we do as mental health? We ask them to set up a routine that is normal. So the first thing is, you're not a patient. Don't behave like a patient. So very often caregivers are the ones who cause mental health problems. Don't do this, eat this, don't do this, you're not supposed to go out, you can't drive your motorcycle or your bike, or you can't drive the car, you can't go for a short holiday. It creates a lot more, they're more conducive to getting depressed or feeling sadness or getting worried that something is really, really wrong. So what we do is ask them to get into a normal routine. You wake up, little meditation, a lot of exercise, take a little bit of effort in yourself, dressing up. Doesn't matter. There was a patient I remember who had a fungating tumor, but she used to come to the daycare in a proper sari, the sleeveless blouse with a nice necklace. She was bald as ever, but she would tie her scarf in different ways. Nail polish, lipstick, and this was way back when daycare had just started. She would tell the other patients, why are you coming in your nightgown? You're not dying over here. And there was actually a change, because everybody got so fed up of telling her why they came in a nightgown. And it's like Dr. Rahul said, 6 cycles. So if I'm doing Monday, it's more or less the same patients on Monday. So they actually took and they made a change in themselves. It was much brighter. So we asked them to pay attention to yourself, pay attention to your family, be as normal as you can, eat when you feel hungry. You don't need to push yourself. It really doesn't solve the matter. Pick up a hobby. And this is something I'm telling you all as doctors also. Because we don't take time off to relax ourselves. Even now, this is a good opportunity for you all to interact, but not when sessions are going on. But forming bonds helps you to cope with whatever's coming in. Indulging in a hobby, whether it's drawing, it's singing, playing music. I think you'll all met Dr. Shona Nakshi, was she there? And she always takes time off to do a little bit of dance therapy, or whether it's exercise. It's her way of, dealing with you all face stress, you all face death every time, you all face difficult patients, difficult family members, and that frustration remains within us. How do we express it out is by healing ourselves. How do I heal myself? By forming good relationships, by treating my body with respect. So I eat well, and I exercise well, and I deal with my stress effectively. That's what we do when we have all our patients. And I just want one clarification with Dr. Joy, gave it really well. Palliative doesn't mean end of life, because very often that is what we as mental health professionals are expected to do. When it is to deal with, because treatment is not working, So it starts from the time that you are diagnosed, and it ends when it's in bereavement or in grief counseling. So we are with the patient right from the beginning and sometimes to the end. Sometimes, most of the times when patients do well, we fade back into the background. So thank you, and any questions? Okay, you all can have can I say lunch?
Yeah, I think, thank you everyone. Being here, please go ahead.